There is coffee here, and restrooms are out this door to the right. I would ask that you not roam around the building, that you would just stay on the first floor. And we will have a couple breaks. There is a sign-up sheet at the front, especially if you would like to make public comment today. And I think that is all I have for you, and I'll turn it over to Dr. Fletcher to officially open the Panhandle Health District Board meeting.
Thank you, Commissioner. Welcome, everyone. I'd like to call the meeting to order, and why don't we begin with a Pledge of Allegiance, please. Flag is back there.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. I want to thank Commissioner Duncan for allowing us to use her facility. I would also like to thank the commissioners of the other counties, those who have shown up, for your participation. I think this is important. Most importantly, I would like to thank the members of the public who have taken their Saturday morning to come. There's a rumor, there's a story that when Benjamin Franklin exited the quarters where the Constitutional Convention was held, he said to the receiving audience, "Gentlemen, we have brought you a republic. Now let's see if you can keep it." Now the word republic actually derives from a Latin phrase, res publica. And res publica translates "we the people." So thank you, public, for being here. Before I turn the podium over to our director, Mr. Kettner, I'd like to address a point. Why are we executing this exercise? Why are we here? Why are we doing this? It has been pointed out to me that there's really no need for this. Things are working just fine. Why look for trouble when there isn't any? Permit me to respond to the why question. 60% of Americans suffer from chronic debilitating disease. We have 100,000 new cases of autism a year. We have countless levels of neuropsychiatric problems afflicting our population. Fertility is in decline. Mid-20th century, fertility was 3.2 children per woman. Today, or per couple. Today, that's 1.6. That is below replacement level, because 2.2 is replacement. Now you say, well, women just want fewer children. Well, almost certainly, women's choice counts for some of that, but not all of it. Because only, 1 in 5 breeding couples are infertile. And our fertility clinics are filled with couples who seek to have children but can't. So we have mental deterioration, physical deterioration. We're losing ground with fertility. And the metric that perhaps is the most meaningful is longevity. So for the entire history of the United States, as a population, we have enjoyed greater longevity. And in the last decade, that has plateaued. And indeed, in the last few years, we are living shorter lives. We have lost 1.5 years aggregate longevity as a society in the last few years. So by any number of metrics, one could conclude that public health is not performing quite as well as it could or should. So to answer the question why, well, I think if you look around you, maybe there's room for improvement. That's the reason why. So with those preliminary remarks, let me turn the podium over to Mr. Kettner.
Thank you, Dr. Fletcher. And I certainly agree with Dr. Fletcher's comments. This is an important time to be introspective about the role that we all have to play in not just public health, but health in general. And certainly we have a number of decision makers sitting here in this room, and I think that is incredibly important, and I appreciate your participation. Predominantly my presentation is going to be a review of the last 10 years of clinical services and what that's looked like. And it tells a bit of a story, but I think a larger question in my mind is how public health is going to look going into the future. And I say that because I think that what we're all seeing in the current federal administration is that we're seeing a push that these responsibilities or health care is an issue for the states. So this is a matter where the state and the county governments are looking to play an increased role. To give you an idea of the perspective or the lens that I'm viewing this, I grew up in Boundary County, about 6 miles south of Bonners Ferry on rural property. My dad was in law enforcement. He did some logging. My mom was a public health nurse. We lived rurally, and the folks, I grew up going over to friends' houses that were living in basements as they had the money to finish the house. I rode the bus in the winter time when we had folks that had grocery bags and rubber bands, because they couldn't afford boots. And I think what that represents is there's always been a fierce nature in the citizens of North Idaho to do it themselves. They're not looking for a government handout. They're looking to do it on their own. But I also think that there was a recognition by the Idaho legislature in 1970 that there was a base need that needed to be addressed. And I believe that's why they established public health districts to address that basic need. And I just, again, want to provide just a bit of context. So the health districts were created in 1970, again, to provide the basic needs, and the focus was on prevention. The focus was on prevention methods through clinical services, nutrition services, environmental services, which we're not going to go into, all of those today. Certainly the focus is on clinic. But at the front end of that, you had clinical services that were very busy providing these services. Family planning clinics, addressing communicable disease, both sexually transmitted and otherwise. And I can tell you, having lived through that my mom, having worked in public health, that the Bonners Ferry office had 4 nurses in that office at that time. Today, we don't have 1 full-time nurse in that office. And that's reflective of the changing landscape of public health and healthcare in the state of Idaho. So we do need to have a conversation on how each of us can play a role in the solution. And I appreciate Mike Baker being here. He represents Heritage Health. I know Kinixu Clinic is also a federally qualified health center, and they're part of the solution. But as we see funding change or dry up, we still do have a needy population that aren't looking for handouts, but they're looking for help. And I think that it's important that we be part of the solution in making them healthy so that they can be active parts of our workforce and be productive citizens. I think that's a basic role that we should be willing to play and able to play. So now I will go into the weeds of clinical services. And I'll be blunt, it's not a pretty picture. It isn't a pretty picture. Basic services that we currently provide, children's immunizations, that's been a backbone. That's kids 0 through 18 years old. We do a number of adult immunizations. Again, sexually transmitted disease, infections tracking and treatment, family planning services, primary care services. Those are what you'd expect from any primary care provider. We do anything from coughs and colds to sprained ankles, everything across the board. And Women's Health Check, which is a specific program to address pregnancy in women, cancer in women. So into the meats and potatoes of the whole conversation. again, the health district was at the forefront of providing these basic services for decades, frankly. We saw, and Mike may be able to answer this question, we saw initially free clinics that popped up to address needs that we could not. We did see federally qualified health centers come into existence in the 2000s.
Yeah, Heritage, so Journey Health Centers started back in 1985. Bonner, they've been up there around the same time, and then they started Bremen Health. They've had a clinic. Probably mid-80s.
Okay.
If anybody would like to speak, we just push this button here, and then we turn green, and then we.
That's what that thing's for.
So what we've seen is a share of the services, and federally qualified health centers work off of different funding than the health districts do. So we've seen, additional care providers pop up that can serve the population that is either uninsured or underinsured. What I want this chart to note is that when Medicaid expansion went into place, we saw a significant drop in our services. And that's expected because then you had more folks that had insurance, you had more individuals that had options on where they received their health care. A few things that were the result of that were that, and I understand it, and we have representatives here that can correct me if I misstate anything, but we saw funding shift from a state allocation that had been in existence since the 1970s, shift to the counties to provide that funding for health district operations. We also saw changes in the indigent fund or other available methods for counties to address those folks that needed care or received care, but didn't have the money to pay for it. So those have happened, and then in recent months, I will say, or in the past year, as we see a shift where the feds are putting more pressure or more responsibility on the states to address these issues, we're seeing need and a potential that we're going to have more folks that are going to be in need of our services. So to me, the fundamental question becomes, what part of the solution can each of our respective entities play that's the best bang for the taxpayer dollars? And that is the question for me. I think that's the question for all of us. Jonathan, oh, there we go. Goes back good. So this is just another representation of the services that were shown on the prior slide, but this lays it out so that it's really more representative, where you can see there was pretty healthy showing in a number of our programs, but without fail, with Medicaid expansion, you saw a pretty steady decline in all of the services except for primary care. And I think what's important to note there is that the community health assessment that was the most recent one that was done, that was wrapped up in early 2024, showed that there's a significant demand for primary care services here in North Idaho. And it's an unmet need. I did not. And that goes, again, back to my fundamental question of there is more need for primary care services, I would say services in general, than we currently have the capacity, whether you talk about the health districts having a role or you're talking about FQHCs having a role. And that is why, both at a state and at a regional level, I've already started discussions, with Mike, that as we see these changes in the funding mechanisms available to each of our respective entities, that we take a hard look at what role should we play, what role can we best play, and what is the best use, again, for taxpayer dollars, because I suppose Mike's working a lot with federal taxpayer dollars, but we're certainly working with a big chunk of county taxpayer dollars. And I was asked, and I apologize sincerely for this chart because it is very difficult to read. I could not figure out a better way to try to consolidate the information, but I was asked what the primary, or the top 10, top 15 services that we provide at the health district, and I don't know if anybody will be able to discern anything meaningful from this particular chart, but it really is representative that it's a little bit of everything and anything as far as the services that folks come in to receive. There is certainly a lot that leans into women's health care. One of the things that's interesting to note is that you see an increased number of folks that are coming in seeking care for anxiety and depression that did not exist years ago. And again, I think that's reflective of our community health assessment, where it was identified that there's a need for mental health support. And our meeting on last Wednesday with Commissioner Williams made a significant point that there is a significant demand for those services. So it's not an arena that the health district has historically been in, but it's certainly a need for the community, and it is to the point that we're seeing folks come in and try to get services, from our nursing staff on that. And in many ways, what our nurses do is they are something of a gateway where they can meet with clients, they can try to address immediate crisis, then they can provide referrals to true mental health professionals that can help guide whatever treatment and recovery they need to for their individual needs. I'd ask if anybody has questions, but there's probably a slew of questions on.
Eric, is there any correlation between the anxiety?
I'm sorry, can you, because the people on YouTube aren't going to be able to hear you.
Eric, is there any correlation between the anxiety and depression and the political presidency?
I would imagine maybe that's part of it, but the way we've seen it increasing over the past several years, I think it speaks to larger societal issues.
Yeah.
I've got my own opinions, but I'm going to keep those to myself and not talk about technology. But I've seen it in my own children and how that's impacted how individuals develop the ability to deal with the real world.
And I made that question as facetiously, but I understand. I've seen an increase in positive attitudes over the last few months. So hopefully that trend will continue.
See Dr. Fletcher with the microphone. Is there?
Are you happy, Glenn? I don't want to interrupt your question. Oh, okay, separate question.
Yeah.
It would appear to me that the categories of care that have enjoyed the greatest increase of recent would be lipid testing and hypertension. So what does that consist of? What does that look like as a point of service in your clinic?
My understanding, and one thing I guess I do also need to mention to the group is that it was my intent to bring a member of our clinical services here today to better answer those questions. Jenna Dow, who was our division administrator, she departed the organization in mid to late March. We've had turnover in staff. Our most senior nurse, who would have been the individual best qualified to be here today, she had a vacation. She is in Cancun right now. So I did try to meet with her beforehand to try to review the questions that were submitted, and I met with clerical staff and others. So I'm going to do my best to answer questions, but getting into the finer details of exactly what these services, I don't think I would do it justice by trying to speculate.
Okay.
Aaron, along that same line, you've probably answered the question, but I mean, how do you let me just ask the question, and you may not be able to answer it, but how do you define a point of contact? What is the definition of point of contact?
Are we talking about like our clinical staff?
For clinical services for sure. Like hypertension, for example, is a point of contact. Someone comes in, gets a blood pressure check, and leaves.
Well, what these numbers are based off is diagnostic codes that our nurses have used based on real clients that they've seen.
Okay, so in other words, if a patient had, yeah, it is, believe it or not, yeah.
It's hard to tell.
No, I'm sorry. Maybe I'm just not strong enough with my voice this morning. So in other words, if someone could be, be a, oh, thank you, sir. How's that? Ooh, my. My question primarily being, what is the definition of a point of contact? So in other words, if it's based upon a diagnostic code, one individual could have 6 diagnostic codes, and so they'd be listed separately because they'd have 6 different diagnoses.
That's correct, and I did talk with our billing staff on that, and this represents just the primary diagnostic code for the reason. So, and bear with me on the answer, but I do understand what you're saying, that
Sure.
they come in for a visit, there'll be numerous codes associated with that visit.
Right.
And this peels out all of those secondary codes, and this seemed to be the best way to present the information, because otherwise you do get a lot of codes, at least from my untrained eye, where, it would say primary hypertension, and then it would say, that there would be various terms that fell within any given category, and it seemed like it could stack the numbers and potentially misrepresent the information.
Well, yeah, in electronic medical records, they just crank out the same thing, and you'll just turn the page, and there are 15 codes for that patient, and they didn't come in for all 15 reasons.
Right.
So in other words, you're really saying that this is based on one diagnosis per person?
Correct.
Okay, thank you.
Yes, Commissioner Horn.
So I would just like to address some concerns that I have and some of our constituents have up there in Bonner County. There's at least 2 private healthcare clinics up there that I know of, Heritage and Kunitsu. I don't know if there's more or not, but they provide the same services as Panhandle Health does, and I'm looking at your top 15 diagnosis codes there, and I believe they all cover those same areas.
Yeah, I wouldn't have any doubt. I'm not going to speak for Mike, but Mike and I, we've talked about this. And this goes, again, back to that fundamental question of what roles can each of us play to best serve the community? Because I have no doubt that the services that Heritage Health or other FQHCs provide, that they either mirror or likely in some respects eclipse what we provide at the health district. But back to that community health assessment where we have a known demand for services and a lack of available services. I believe there are questions that have been received as far as how long it can take for any given individual to get in and see a care provider. And I know in some respects we can get folks in same day. Other folks that have additional needs, we're looking at 2 to 4 weeks out. I don't know what Mike's turnaround time is, but the demand is there. We talked about this the other day. At this point, we're not competing for clients. The demand is great enough that there are folks coming to our doors because we can get to them maybe a little quicker than Mike. There is no shortage of demand in this population.
So that was my main concern, and I would like to see some data on that as far as, are there patients being turned away by the private sector that we're filling that void? Well, I don't think it's right for a government entity to compete if there's a private sector providing those services, because our government entities are funded by taxpayer dollars, and I don't think it's fair to the private sector and the private businesses that are contributing to those tax funding that there actually could be losing business. So I'd like to see some data on that.
And that's a good question. That's a valid question. One thing I definitely want to clarify is that Kunitsu Clinic and Heritage Health are not privately operated facilities. They are also largely dependent on public funds, federal funds, to keep their doors open. And I think it's important, really what we're talking about is we have federally qualified health centers and we have the health district that has sliding scales. We do take insurance, folks that have insurance, we do bill insurance. But we also charge fees. Most of the services we can slide based on demonstrated income. They have to demonstrate that they have qualifying income with 2 pieces of documentation, and we can slide as far down as 50% on most services. I believe family planning, because of Title X, we can slide down to 0, but that's getting to be a trickier and trickier one as funding becomes less available. So the population that we're talking about and that we're serving, I would argue that most private clinics are not interested in them because they're not paying full price. So I don't think we're stealing anybody from the private sector. I really don't. But I can certainly try to pull some information on that.
Thank you.
Any other questions? So again, another bleak picture. Where are we at with staffing? I'd go back to the last slide, but I don't want to for fear that I wouldn't be able to jump forward. But 10 years ago, we had 15 medical staff at the health district providing services. Today, I'd like to have 6 on. That would be reflective of partly what we can afford and partly the demand that we're currently seeing or that we do see out there. Right now, we've got 1.5 nurse practitioners, 1.4 full-time equivalents of registered nurses, and 1.5 medical assistants. We've got vacant positions, as you can see, total adds up to about 6 people that I'd like to have on staff. We also have a relationship with the Kootenai Health Residency Program, in which they bring a doctor, Dr. Chase, into our clinics 2 times a week. She typically brings in a resident with her, and they roll through clients as well. With this limited staff, as I'd alluded to earlier this morning, we do not have full-time nurses in each of our offices. The clinical staff that we do have rotate through offices. Currently, we have folks in Hayden, medical staff 5 days a week. We have staff in Sandpoint one day per week. Sorry, did I say Hayden 5 days a week? Hayden 5 days a week. Sandpoint 1 day a week. Shoshone and Benawa 1 day a week. And Tim, we're having folks from Bonners Ferry come down to our Sandpoint clinic at this time. So no, we have a very, very limited number of staff working. And that's reflective of 2 things. The first is that there's a very small pool of medical professionals in this area to pull from, and everybody's looking for them. Kootenai Health is looking for them. Heritage Health is looking for them. Northwest Specialty is looking for them. Everybody is competing, and that's driving the wages that they can demand up. So as we've tried to maintain equity, within our staffing wage, but also try to address need, we've been slow to build up a more robust nursing staff. And that, I will say, goes back to my fundamental question of what need can the health district best fill? And I want to have the answer to that so that I can take the limited and valuable resources that we have, that we receive from the county, and I can invest in the necessary medical professionals that can best fill the need that we can address. And that's going to be, the answer to that, in my opinion, is going to come through conversations with federally qualified health centers, with hospitals, trying to decide what role each of us should be involved in.
Eric, may I ask a question?
Yeah.
You said that 10 years ago there were 15 medical staff. And you have the breakdown of the current medical staff, but do you have the breakdown of what those 15 were 10 years ago?
I do not, but I believe it was predominantly, I don't know if I should lean on Peggy for this, but we had quite a few nurse practitioners and nursing staff that were, we've not historically had doctors on. I don't know if that helps answer the question. It's been nurse practitioners and nurses that have been the bulk of that 15.
I mean, because I'm trying to get a feeling for, like, for example, right now when you say 1.5 FTE nurse practitioner, to me that's a medical provider per se. And so in essence, you have 1.5 for 5 counties, and is that 1.5 per day? So in other words, it would be 2 people every other day would ends up, I mean, how do you calculate 1.5 nurse practitioners? I'm looking for
Sure.
medical providers.
And I would say that our nurses are medical providers. Certainly our medical assistants, they assist so that we can maximize our time for our nurse practitioners, where they'll come in, they'll take height, weight, blood pressure, that type of thing, so that when our nurse practitioner or nurse does come in to see the patient, they're not doing all of that legwork. I'd imagine it's similar in a private clinic.
Sure.
But to maybe more directly answer your question, we have one full-time nurse practitioner, and then we have one half-time nurse practitioner. And the way they're splitting their responsibilities is the half-time one is splitting her time between Shoshone, Benoit, and sometime in Kootenai County. And then the full-time one is splitting her time between Kootenai County and Bonner County.
Okay.
So that's why we're having one clinic per week in outlying offices, whereas we have services 4 to 5 days a week in the Hayden office.
Okay, I mean, yeah, because as a provider, I think that there's a difference between, I mean, just gives me an idea of the medical services provided when you've got a medical provider like a nurse practitioner or a physician versus a medical assistant. You know, I mean, what is, and that's why it gives me more of an idea of what the intensity of needs and what needs are being met. There's a difference between a blood pressure check and someone coming in with acute abdominal pain, or as far as they're not equivalent. In other words, the intensity or acuity goes up significantly with what a nurse practitioner can handle.
Absolutely understood. No, our nursing staff understand that, I think, better than anyone.
Right.
And there are basic routine services that our registered nurses can address, and more complex issues that do require a nurse practitioner to be involved.
So that's why that gives me more of a feeling than if you felt at the time. That's why I think as a physician, obviously, to a certain degree, because that to me is since I am one. So from that, when you talk about 15 in the past, if there were 5 nurse practitioners or 6, and now there's 1.5, it gives me an idea of the level of acuity per se too. That's why I'm trying to get a feeling for that definition. It looks like Peggy's got it.
No, in 2015, we had 3.5 nurse practitioners.
3.5 in 2015.
Correct.
Okay, got it.
Thereabouts, because that's about the time. I went part-time and we hired another part-time, so it could have been 3.
Okay.
Somewhere between 3 and 3.5.
Okay.
And for example, when I worked, I covered 3 counties. I used to go to Hayden once a week. I went to Kellogg once a week, and then I was in, depending on where the need was. And if a nurse practitioner went down, then I could go to Hayden every day. So
Okay, right.
quite a bit of travel involved.
So in other words, we're also not only seeing a decrease in services per se. I mean, I'm just trying to define, but it's somewhat of a decrease perhaps in acuity too, because if that went from 3.5 to 1.5, there's been a decrease in acuity over the last 10 years as well.
Well, I think, so what you have to understand is about 2015 is when the Care Plus or the primary care was added. Prior to 2015, Panhandle Health nurse practitioners mainly did family planning, reproductive health, women's health check, and STD.
Okay.
They weren't managing more complex, like abdominal pain. Well, I mean, we did manage abdominal pain.
Sure.
In STD clinic. But so that model changed.
I see. So from 1970 to 2015, then basically that's what it was primarily. Got it.
Correct.
No, that's really helpful, because it's a defining of terms and acuity. Okay, thank you.
So some considerations, some points that I think have been hit on already. Again, our most recent community health assessment, primary care services are in demand. There are more clients than there are services available, regardless of what Heritage Health can do at this time, the health district can do, what private care providers can do. The demand is to see a care provider in a timely manner was one of the primary identified issues in that assessment. We're seeing additional criteria applied to qualify for Medicaid expansion at the state level. trying to continue to monitor what's happening at the federal level, there were some fairly significant proposals on the table to, going as far as eliminating Medicaid expansion entirely. They're looking for significant cuts in health and human services budgets. I think where they're landing is leaning toward adding national work requirements for Medicaid expansion. There's still a lot on the table as far as where that stands, and there's still significant dollars they're trying to find to make that budget come together. That's where, for me, I think that where they land, because they're looking at cuts that would not just impact the health district, but they would impact federally qualified health centers. And I think that, to me, what we want to try to avoid is we want to figure out how we can provide these preventative services so that these individuals that don't have access to care aren't landing in hospitals. They're not landing at Kootenai Health. They're not landing in our small outlying community hospitals, which don't have the resources or the funding to address this issue by themselves either. So, again, we will have a much better idea of what funding is available to the health district, what funding is available to FQHCs, and how that's all going to fit in coming months. And I think I got to this third point in that conversation, is that predominantly, if you want to talk about entities that are providing services at a sliding scale, you're looking at it right here. You're looking at the health districts. You're looking at FQHCs. That's who's there. We are the ones that can be best utilized to address this issue so that it doesn't become an excessive burden onto the area hospitals. That's how I am viewing it at this time. Through this slide this demonstrates, I know it's a bit hard to see, it demonstrates persons without insurance under 65 and poverty levels in our 5 northern counties in respect to the state of Idaho and the U.S. average. And I think, as you can see, with small exception in Kootenai County and to some degree in Bonner County, we have very high uninsured and poverty rates in North Idaho. And with changes to Medicaid, medical coverage, those type of things, I think that we can expect the demand for those services to increase in coming months. And I want to be proactive. I want to have the conversations and figure out what we can do to be ahead of the curve on that. So, again, somewhat redundant here, but who's going to provide basic preventative care to the uninsured? What is the cost if it's not available? Again, back to fundamentally, public health came into existence because the legislature recognized that there's a basic need to try to have a baseline of health for the citizens of Idaho. How can PhD best partner with stakeholders to meet the needs of the community? Again, I think those are conversations that need to be happening in real time as we get a better picture of what funding looks like. And at what point does lack of access to preventative care transition from a private health matter to a public health issue? So those are questions I just want to, I think they're guiding questions as we consider this issue and as this group and elected officials look for answers on how we can best address it. That's the end of my presentation. Any questions for me? All right, thank you.
Thank you, Eric. So I'm next up, and following me will be Dr. Johnson. I'm going to pivot the conversation here and take, if you will, a broader, more philosophical view of what is meant by public health and what do we want from public health. Let's begin our story roughly 5,000 years ago. Archaeologists tell us that if you examine carefully some of the remains of the Mesopotamian city-states, you will already find evidence of public latrines. So in the earliest moments of human civilization, we had a primitive understanding of management of our effluent. Effluent is a polite way of saying urine and excrement. I'll stick to effluent. By the Bronze Age, the engineering of this management had evolved to the creation of clay conduits to transport the effluent. Fast forward a couple of thousand years to the apex of the Greek civilization, and a deeper understanding of the management of effluent had developed to a considerable degree. Hippocrates, who is considered the father of medicine, wrote a treatise entitled Water, Soil, and Health. And frankly, it is a manual for the Department of Environmental Quality. So Hippocrates could be considered the father of public health as well as the father of medicine. By the Roman times, the engineering of the management of human effluent had reached really an apex, and infant mortality or childhood mortality had been reduced to the level of roughly 200 per 1,000 live births. Now, with the fall of the Roman Empire, Europe went into some chaos, and over the centuries, going into the Dark Ages, there were periodic plagues, and overall hygiene of the communities of the urban centers deteriorated. At its nadir in the 12th, 13th, and 14th centuries, childhood mortality had increased to 800 per 1,000. So a substantial amount of the hygiene that had been achieved by the Greeks and the Romans had been lost. And it wasn't going to be for several hundred more years of civilization in Europe before that ground was regained. So we go through the Enlightenment, Scientific Revolution, Industrial Revolution. In fact, some of these moments in European history were rather filthy. The Industrial Revolution, for instance. Life was short and brutish. By the end of the 19th century, and certainly by the time we hit the 20th century, the principles of management of the effluent, and in general the principles of the management of the environmental quality had improved. Probably one of the more important anyway, inventions was the microscope. Because with that, you could identify little things. And once you can identify little things, bacteria, single-celled organisms, with that you can now study their biology, their life cycle. And with that you can have a deeper understanding of now how you are going to manage effluent and the transmission of infectious disease. So the crowning moment of public health in world history occurred roughly between the beginning, the dawn of the 20th century, and mid-20th century. I'm a baby boomer. I got to enjoy one of the big moments in public health, if you will, where the odds of my surviving into adulthood had arrived from, say, 200 out of 1,000, say just before the dawn of the 20th century, to by the middle of the 20th century, only 10 out of 1,000 would die. In other words, 990 live births survived. Well, that's profound. Public health had accomplished a veritable miracle in that period of time. And for that reason, I want to go on record, I'm a great fan of public health. Now, that being said, we have a paradox. Remember my opening remarks. I said, gee, we're getting sicker. Well, how do we reconcile this? Public health performed brilliantly in the management of the affluent, and yet in the aggregate, today we are sicker. Today we are less fertile. We're not living as long. How do we resolve this paradox? Well, now in my readings, bear in mind, I am not a public health expert, by no means. In my readings, I came across a concept that's borrowed from the discipline of economics. It's called management of the commons. In fact, a Nobel Prize was awarded in 2009 to an Eleanor Ostrom for the development of this economic concept. Management of the commons. Now, what is the commons? The commons is defined as an asset or resource for which everybody owns it. Example, the Spokane Aquifer. Doesn't belong to any of us. The Spokane Aquifer belongs to all of us. And so it is incumbent upon an urban group of people living together that there be wise management of a common asset. Well, quite frankly, Hippocrates nailed it. That's what he said. He said, preserve your water, preserve your land, so that these resources can be enjoyed by a larger population. Otherwise, if you fail to do so, then you have a tragedy of the commons. You spoil your environment. We don't want that. So if we've done so well, following, if you will, the principles of Hippocrates by the mid-20th century, why are we getting sick? Now, in the concomitant with the development of microbiology and material science and an understanding of how to manage wastewater, public health took on additional roles. So in 1906, the Food and Drug Administration came into existence. The federal law, the Food Safety Act, and the original commissioner of the FDA, Harvey Wiles, or Wiley, gave birth to that legislation, federal legislation. He helped bring it into existence, and he served as the first commissioner of the FDA. And he served for 11 years until he resigned. And he resigned because he said that he could not overcome the influence of the food lobbyist. Now, this is at the beginning, the origins of the FDA. Okay? At the same moment, early 20th century, public health went into the business of management of fertility. Margaret Sanger and the development of women's health, reproduction. I'm not going to go into the tall weeds of all that. You can bring from your own experiences in readings the travails of public health interventions in fertility over the course of the 20th century. Now, by the time you get to the late 20th century, and certainly now, here we are, the 21st century, by a number of indices, public health is not performing as well. I referenced all that in my earlier remarks. So how do we make sense of this dichotomy, this paradox? On the one hand, public health has performed brilliantly, and yet on the other hand, there are failures. What gives? Now, upon reflection, I'm thinking to myself, well, what is public health, for the most part, for the last 5,000 years, as Hippocrates had discussed, was about management of the commons. But then, in the 20th century, there's another element to the portfolio of public health. So what does it manage? Well, if you look at the word commons, that is an asset or a resource that belongs to all of us. So I ask you, is there an asset or a resource that belongs to nobody? In other words, it is an asset for which there cannot be ownership. Well, certainly that does not apply to automobiles. You can own automobiles. It doesn't apply to this room. The citizens of Kootenai County own this county building, to land, to all kinds of items you can think of that for which there is some traceability of ownership. But what's the thing you can't own? Well, now, if you follow the teachings of Jesus Christ, and if you happen to be of a more secular orientation, the teachings of Thomas Jefferson, the answer to that question is us, human beings. We have inalienable rights. We cannot be owned. We have agency. We are not an automobile. We are not a building. We are human beings. So now if you want to unpack the paradox of the performance of public health over the course of the 20th century, consider this. In the spirit of Hippocrates, public health was management of the commons. And as the 20th century evolved, and as the portfolio of public health endeavors evolved, it became management of the sovereign of individuals. So actually, there was a profound transformation in the very behavior of public health. Now, for 5,000 years, public health had a way of operation, and for the last 50 to 75 years, that operation has changed. So my question to all of us and to our civilization, do we want, moving forward, the face and operation of public health to get involved in the management of the sovereign? Thank you. Any questions? Well, given that.
I just have just a clarifying question, maybe.
Uh-huh.
You're talking about management of the sovereign. I'm trying to understand that. It's like the services that we provide are predominantly voluntary, whether you're talking about women's health, STDs, those type of things. There's people come in the door to receive those services. Frankly, the regulatory ones where we are, in my opinion, more imposing are the land and water. We're regulating individual properties. We're regulating the aquifer itself is a good example where we're taking an active role in people's personal property, which is a big deal in Idaho. It's a big deal across the country. But when we talk about medical services, those are predominantly voluntary services here in Idaho. So if you could clarify between...
I'll be happy to.
Yeah.
But bear in mind that the policies that you follow are established by the CDC and the FDA. And that's where my critique is leveled. Panhandle Health, you personally are fine. Your nursing staff are fine. I have no complaints, none whatsoever. Don't take it personally. I'm talking at a policy level. That's where the derangement is coming. It's when the government, the federal government, gets involved in the management of the sovereign. Let me give you an example, trivial example. The WIC program. How can you possibly be against providing for, unwed mothers, a new baby? Give them some formula, some diapers. This is just a wonderful thing. This is mom and apple pie. You couldn't be doing anything better. And that would be from your heart. I mean, you honestly think your WIC program is serving a need. Well, let's examine what's in baby formula, commercial baby formula. Commercial baby formula There are 72 brands on the market. All but 5 are reinforced with high fructose corn syrup, a product that is not in human milk. Human milk has 2% linoleic acid, which is an omega-6 unsaturated fatty acid, which is an essential fatty acid. You have to have it for subsequent generation of a variety of complex steroids to include estrogen and arachidonic acid and other biomolecules. So you have to have some linoleic acid. But human milk has 2% of the constituency of fatty acids consist of linoleic acid. Formula, because it's made from, because linoleic acid is basically seed oil. It's canola. It's cheap to make. Well, where are the calories from formula coming from? Seed oil. And so the constitution of the omega-6 fatty acids in formula is anywhere from 10 to 20%. So you've got a source of glucose, namely high fructose, or I shouldn't have said glucose, a source of carbohydrate, which normally should be lactose, which is a natural sugar that infant mammals can digest, and you replace it with a simple carbohydrate that is undigestible, and you flood the liver with a fatty acid for which you don't have the enzyme systems to handle that load. Infant formula is not healthy as sold in this country and as promoted by the face of public health. So it isn't that the intentions are wrong. It isn't that people need services. I'm saying that what is being promulgated by the federal government, by the FDA, CDC, is not necessarily healthy. And if you challenge that, and you're certainly welcome to challenge that and anything else I say, look around you. How sick are we? Do we have problems? That's the point I'm trying to make. Did I answer your question?
You did. One point that I'd like to clarify, I don't want to speak too much for our nursing services, but as evidenced by the home visiting program and by the breastfeeding support folks that we have, there is no doubt that breastfeeding and natural milk is the way to go. And we certainly encourage that as the starting point for every mother, and that is the focus. I'm not going to get into the weeds on the nutritional value of formula, but I can tell you that that's a last resort. And I'm not saying that there's not a better way, but we are certainly not pushing mothers to not provide natural milk in lieu of formula. So just.
Do you teach mothers how to make their own formula?
I don't think that we've.
You could. It's doable. Any other questions? Yes, sir.
So not necessarily a question, but a comment. You brought up the management of the sovereign, as Eric kind of asked a question on it too. And a couple things came to my mind real quick. Childhood immunizations. So we talk about managing the sovereign, which is the populace, the people, the citizens. We're told today, and I'll call it lying too, we've been lied to today that we have to do this to our children. We have to do this in order to enroll them in a public school. There's no information ever given to the parents stating that, hey, if you don't want to immunize your children, you can sign this form, this exemption form. That is not readily available. I think that needs to be brought up. It needs to be talked about. I don't know if that's really anything that the Panhandle Health District can do to try and make a better, maybe education part. But I do know, like in your clinics, I would like to know if the nurse practitioners are telling the parents, this isn't necessary, this is what we're recommending, or this is what the CDC is recommending. Where are the recommendations coming from? Which kind of leads me into my second one, and it's been talked about before, and I wasn't going to bring it up, but it relates, is our informed consent that we have been talking about here in these meetings for the past 3 months. Where is the informed consent from Panhandle Health District when new parents or a new mom takes their infant in and they're being told that you need this cocktail of vaccines and the CDC recommends it, or again, I'm not sure who all recommends it, but where's the informed consent of the repercussions of all of these vaccines? And I know I've heard you talk before, Dr. Fletcher, and I appreciate all of your knowledge that you share with the people as far as a lot of these immunizations, when they go through FDA testing and stuff, or some of them are only tested for 2 days, if I remember correctly. And some of them have only been tested for 5 days after the vaccine was administered. And after that, it's not looked at anymore. We all, as a public and citizens of the freest nation in this world, should be asking why. Thank you.
Well, the topic of informed consent for immunizations was introduced at the board level, and there was no appetite of the board members to pursue that conversation, so it died. Did I answer your question?
Commissioner McCorn, if I can just add to that, we are required. First off, it's a voluntary service, so folks that come in our doors, we're not out dragging people in off the street and giving them shots. But secondly, we do provide vaccine information sheets as required by law. Those are prepared by the CDC. I know there's some contention on that, but we do provide that, and I do believe that we're also required to inform individuals getting vaccines of available exemptions to them. So there is information that's provided when those services are rendered.
I would ask everyone in this room to examine for yourself the risk-benefit sheet that is created by the CDC and given to the patients. Don't take my word for it. Don't take anyone's word for it. You find this piece of paper and you read it for yourself to see if, in fact, all of the relevant information is contained on that piece of paper. Again, don't take my word for it.
I would echo Dr. Fletcher's comments. I think that every individual should do their own research. They shouldn't rely on any single source. And I think that they should have a meaningful conversation with their physician and make the best decision for themselves and their family. Fundamentally believe that. It's not every answer is right for every individual. So do, by all means, and I think Idaho is the state. I think the expectation, the way Idaho is devised, is personal responsibility. Don't expect somebody else to do it for you. You got to expect that you're doing it yourself. Do your own homework. Be informed.
And I appreciate your comments, Director. And I guess, unfortunately, in the past, baby boomers, since I am at the tail end of that one, we have become trusting in our healthcare providers. And we've gotten used to listening to our doctor's advice. And if the doctor's advice or the practitioner's advice is to do this protocol, then unfortunately we have become a nation of accepting that. And it's like, well, they know best because they are the professionals that have gone to school for umpteen years and studied this. I'm just a layman. I'm just a construction guy, and I don't know any different, so I'm relying on your expertise to tell me. And that's where I have a problem, is I don't think that information is being shared. In a world that we live in now, that we can't buy anything in the grocery store without having a whole list of ingredients of what's in it, why isn't that in our immunizations? Why isn't that handed to us as a packet? I'm sure the healthcare, Panhandle Health could print something up, a nice little trifold brochure. Here are the pros and the cons of this vaccine or that vaccine or this cocktail of vaccines. I would like to see, we talk about public health care. I think that would be a huge service to our citizens if we were allowed to have something like that, even if we could take it home and look it over and read it, and then the people are able to make their own decisions. Because it's really hard to make that decision without that information, and I would like our government to provide that information for us.
Well, that's an interesting comment, that government would provide it. I would say that now more than ever in history, we have access to information. We have the internet. One could argue there's an excess of information available in order to make an informed decision. But I would say that the other important thing to do for individuals is find a care provider that aligns with your belief system. There are a number of care providers that do take maybe a more holistic or a naturopathic approach to this. And they're going to, if their viewpoints are aligned with yours and your family's, they're likely going to provide guidance that moves you away from vaccines or certain vaccines, or based on your health conditions, certain directions. So I don't know if the role of the local health district to provide all of the answers is appropriate in this age of significant information, and if you have insurance, medical choice on who your provider would be.
And I appreciate that, but I'm coming to you because I'm in poverty and I'm uninsured. I am your client, and I'm not getting that information from you. As an uninsured person or someone in poverty, I can't search out those more holistic avenues because I don't have the funding for that. But yet I'm paying into the tax system to support Panhandle Health District. Why shouldn't I be able to get those benefits from you guys?
If I may interrupt at this point, pretty please. Your conversation is vital. And pick it up again when this man takes over, because you're actually involved in the very process of the workshop. The point here is to present some overview data, and then set the stage, and then we'll turn it over to Seth. Commissioner Corn, I have a lot of respect for you. I want you to keep your spirit. Director Kettner, hang in there, but let's do it when he takes over.
And Commissioner, by all means, we can speak in length outside of this meeting if you'd like. By all means.
At this juncture, I'd like to turn the mic over to our medical director, Dr. Johnson.
Thank you very much, Dr. Fletcher. My topic is the options for the direction of the public health clinics. First of all, as becoming a board member, I want very much for Panhandle Health to be able to provide the best medical care that we can to the community, and yet what I found out since being on the board, as Eric so clearly explained, is that the participation in the clinics has gone down. And as a healthcare practitioner, your first thought is we must not be providing the care that they need because they're not being utilized. It's not as if there isn't a need for health care, and it's not as if there aren't people who can't afford health care. There are a significant number of people in North Idaho who can't afford health care, and so the question is why then, therefore, aren't these services being utilized? We must be doing something wrong. I'm taking responsibility for that decline. It's not in any way, shape, or form that I want to diminish them or remove them. Some people have misinterpreted that our asking of questions means that we want to somehow eliminate health care being provided to those who don't have access. And I take responsibility for the lack of communication on that point, but that's a misunderstanding completely. So that is, of course, one option would be to eliminate it. But at the same time, I don't think that when the demand is so great and so high that that's the direction personally that we should be taking. We should step back, take a look, and instead of saying, wow, it's going down, we think it might be this reason, we think it might be that reason, but if we don't really know, then we're not meeting the needs of the community. And it's very important for us to step in and really understand what the voices of the people are so that they can have a trust in us so that we can say, yes, this is a service that we can provide. This is, and we are able to do so for you, and you can trust us. And so there seems to be a lack of trust or lack of understanding of what is being offered. And that, for me, is the purpose of this exercise. What is the future? Are we going to sit back and say, okay, it's not being utilized, and of those services that are out there, a lot of private physicians have waiting lists that I know are weeks and months out. Patients come in and tell me, in my private practice, I was told I can't see this particular person for 3 months. My appointment is X number of months out. Well, obviously there's a need for healthcare. And if our clinics are not being used and other clinics have a waiting list, then we're not doing something right. And I think we can improve it. It's not from the point of view of let's eliminate it. No, we need to improve it. So how do we improve it? It's well known, at least in my career, I've been either the co-owner or medical director of at least 5 health clinics or practices. And one of them was a industrial medical practice. And when we took it over, the industrial medical practice, it was declining significantly financially, and it was about to go under. And within 1 year, we had increased the volume of that clinic 6-fold. And it was because it was improper management when we walked in the door. And so that's my view, that somehow I'm taking responsibility, somehow something isn't right. And we need to find out what's right. We want people in the community to say, wow, Panhandle Health is a place I can go to. They're going to take care of me. They're going to provide good care. They'll help my family, and I'm confident in driving down to Panhandle Health. Now, what I also know is that I've been was the medical director of in essence, a preventive medicine practice where we would go in and provide health risk appraisals in major corporations. I'm a native of North Idaho, but this was in Southern California at the time. And we had huge customers, and it was known at the time that for every dollar spent in prevention, it saved $9 in healthcare costs. Now, those numbers may not hold today, but when I was doing preventive medicine on a large scale with major corporations in the 1990s, that was a number. I would assume it's roughly equivalent today. If we adequately provide good, solid preventive medical care, we will reduce the load at Heritage Health. We will reduce the load at Kootenai. We will reduce the cost, because ultimately, when somebody goes to Kootenai and if they don't have funds, the public is ultimately paying for that health care in the emergency room or those surgeries or those problems. And so if should we eliminate the care, in my opinion, at Panhandle Health? No. We need to do it better. And one of the ways we can do it better is by providing outstanding prevention, outstanding services, so that people really truly know how they can take care of themselves, know how they can take care of their children, how to provide good food. You don't have to eat the food that has 15 ingredients, et cetera, et cetera. I mean, in other words, we can, and it was because of, in just one particular company that I worked with, they had over 800 employees, and within 1 year, we saved them 25% of their healthcare costs. Now, you can imagine the medical costs for a company at the time, and the company was providing healthcare costs for all of their employees. Saving 25% of 800 was a ton of money we were saving that company. Well, the same thing could be translated well to the county level if we step in, step back, and say we need to reevaluate what we're doing and do it better. That takes the pressure off of the public. Now, philosophically, there's the federal government providing health care and local services providing health care. I think philosophically for me, I think local control is better than federal control, because I don't think that somebody who's sitting in Washington, D.C. knows North Idaho, and or they don't know every single part of the country. Healthcare needs are different in different parts of the country. So a federal government, though it's nice they're providing money, they're not going to really understand. And that's why it's up to us to say, okay, we know what's going on in North Idaho. We know the needs that are here. We know the people. We have patients that are here. And there's uniqueness to North Idaho that's not the same as downtown LA, where I've lived or worked. And so, in other words, we need to provide a medical service that is unique to North Idaho with better local control. And that's why I can see where Panhandle Health at the county level can perform a tremendous service and be outstanding. And if we go down that pathway of providing true preventive medicine and work hand in hand with the other groups, what we're going to be able to do is save healthcare costs across the board. And so, but in order to do that, there has to be a trust within the community. North Idaho, I'm a native here. My great-grandfather homesteaded when Idaho became a state. I am a real North Idaho guy, okay? And so I know that North Idaho people have a tendency to not trust when you walk into a building and somebody says to you, do this, trust me, you can do this, I'm telling you, this is what you need to do. That's not North Idaho people. You have to prove your trust. You have to prove that you care. You have to prove that we're not forcing something on you. We are proving that here's the information, here's the data, you make the decision, and we're here to support you. If we do that right, people will come. And that's why, yes, I can see where there's a lot of reasons why maybe these numbers have gone down in the last 15 years. Maybe it's completely a financial issue, but I don't believe it's completely a financial issue. I believe it's a performance issue. And it's easy to not take responsibility. I'm trying to take it. I'm trying to put it on myself and as a board member and say, what can we do as a board to be better at what we do? So please know that that's my purpose for being here. It's not to eliminate, it's not to take away, it's to be better at what we do. And I think the more that we do it better locally and more transparent, and there has to be a transparency. Transparency is incredibly important for North Idaho people. It may not be important for someone in a major city, but for people here, if they're going to participate and come to the clinics and not have to wait for months or not receive it at all, they're going to have to trust who it is they're walking in the door to see and know that that person has their back. And that's where I hope we trend as a board to be willing to break away from the status quo and sit back and say, oh, their numbers are going down and we don't know why, that we step in and really do something good so that when we leave this board, it's thriving, it's reducing the healthcare costs across the board for not only the public agencies, the insurance companies, for Kootenai Health, for everybody, and lowering the healthcare costs and improving the health of everybody. So hopefully that gives some clarification, and hopefully we can go in that direction to accomplish that. Thank you. Any questions?
Dr. Johnson, I appreciate your comments, and I do believe everything that I've said that I've seen and read is that prevention is the path forward, and certainly rebuilding relationships is critical. Two things that I think are important to note is one is, and I appreciate your stance on as the board that we should be proactive and looking forward, and that's very much certainly the philosophy that me and my staff are taking as well. That's thus the reaching out to federally qualified health centers. What can we do really well with the limited funding that we have? Mm-hmm. But that is a major factor for all of the entities with the populations that we serve is that we have limited funding. And I would say the biggest reason that we have in the last year that we have a decrease in folks coming into clinic is capacity. you saw the numbers.
Mm-hmm.
You can only do so much with, with 3 nurses in 5 counties. So,
Do you think,
Do-
no, no,
Gen-
and
gentlemen.
I appreciate that.
I don't want to take his thunder away from him.
Okay. No,
It's a great question. No, seriously, Eric, you asked a super question. But once again, I think that this is the guts of our workshop dialectic.
Absolutely. If I may just respond to that, are the full-time equivalents absolutely packed?
yes, they are.
So in other words, there's no room, there's a waiting list, people have to wait many days to be seen.
There are some questions we can talk about that, but yeah, we have an excess number, just like I'm sure Mike can attest to, that are looking for appointments.
See, that's an important point. And see, that's the information we were trying to get, because in other words, all we knew was that numbers were down and there wasn't participation on previous board meetings that we'd attended. The clinics were empty. So in other words, that's what's confusing to me, that when you guys went around and visited, there were spaces. So that's where the definition of terms is important. What is a visit? How many? What are we seeing? Because we can't, unless we know the data, we can't make those improvements. That's all really important. So thanks for clarifying that.
Thank you. And listen, please pick up this conversation later. I don't mean to engage in censorship. Why don't we all take a 10-minute break, and we will reconvene, and when we do, the floor will belong to Mr. Grigg.
It's so confusing because it's
People in the room know who I am, but not everybody does. My name's Seth Grigg. I'm the executive director of the Idaho Association of Counties. The Idaho Association of Counties was founded in 1976 by counties across the state, basically to bring counties together so that we can facilitate discussion of ideas. We conduct trainings and other events on behalf of our member counties around the state. And we also will represent the counties before the Idaho legislature on issues of importance or of impact on counties. And this is an exercise that I undertook last summer. The Board of Health Districts, the statewide group, invited me to participate with them in Idaho Falls when they were together from all over the state to engage in some strategic planning, SWOT analysis, because there's a lot of change going on right now. And some of that's the result of legislation that's been enacted. And so to lead things off, I do want to talk a little bit about really some of the legislative items in Idaho over the last decade. I'm going to give Representative Redmond an opportunity to talk a little bit about his involvement with some of those, and also federally some of the things that he's been involved in, just to provide a context as to really the role of counties in dealing with public health districts, in dealing with medical services. You might not think of a county as a key player in the medical area, but over the years, there's certain responsibilities that counties have had. Just kind of background about me, so you know a little bit more about me. I'm an Idaho native, love Idaho. I'm a big baseball fan. I've got 2 teenage sons that are heavily involved in baseball. I bleed counties, and I have to wear that on my sleeve. And it's in my blood, literally. My great-grandfather was county sheriff in Madison County, and my grandfather was county sheriff in Washington County. And so, I think because I've got that in my blood, I really gravitate towards counties and county government. I also believe that when we talk about governance, the best governance is that government which is closest to the people, and in my view, that is the county. The state and the legislature are responsible for enacting laws and regulations around the state, and then they delegate to counties, in large part, the administration of those laws and regulations that are implemented. So when we're talking about the role of counties in public health and how that has evolved over the years, counties have, likely since the inception of counties in Idaho, have had some responsibility for assisting when individuals don't have the resources to be able to, pay for their medical care. And, over the years, historically, neighbors helped each other out. Churches would help people out. There was a lot of community support. As we got into the 80s, the 1980s, there were a lot of folks that did not have insurance, that required medical care, and they had no means of paying for it. And so in Idaho, counties had that responsibility to assist with those expenses as they come up. Counties are very entrepreneurial in the state of Idaho. They came together and created what was at the time a voluntary program for counties, where all the counties that wanted to participate got together. They contributed funds based on the population of the county and a number of factors. They pooled those resources and then would draw from those resources when these emergent medical care situations arose. It proved to be such a successful program that the legislature in 1991, they actually codified that program as it was known as the Catastrophic Healthcare Cost Program. A lot of people shorthand will refer to it as the CAP program, if you've ever heard of the CAP program at the state level. When the state codified this program, it became essentially a cost share between the counties and the state, where the counties were responsible for the initial, and it evolved over time. It was different levels. Most recently, before the program was repealed, the counties were responsible for the first $11,000 of indigent medical expenses. And we're talking emergency expenses. We're not talking preventative health. You have a heart attack, you go to the emergency room, you don't have insurance, and you can't pay your bill. The county was responsible for the first $11,000 of those expenses, After that, it would kick up to the state of Idaho. The CAP board would review the application. The board was comprised largely of county commissioners, and then the state would pay the balance of the expense, cancer diagnosis, things of that nature, and the treatment of cancer were the types of programs and services that were covered. And it was all a reimbursement model. And so if I incurred a significant expense, I couldn't pay for it, there was an application I would file with the county. They would process the application, pay the first $11,000, forward it on to the CAP board, and then they would make the approval. Review process, but it was quite the program that was, again, it was set up to provide a safety net for those individuals that had an emergency expense, medical expense, and didn't have the means of paying for it. You fast forward from 1991, when this program was established, to 2000, and I believe it was 2020. Let me take a step back. It was 2018 when the voters approved Medicaid expansion in Idaho. It was then implemented as a state in 2020. So what we saw happen at that time, and it's interesting if you look at the data and some of the timelines that Director Kettner shared, that's when you saw this kind of drop in services. And I think some of that can be, not all of it, but some of it may be attributed to Medicaid and the fact that more Idahoans had access to health care through Medicaid, so they were able to go into more traditional means of health care. We saw the same thing happen with the county indigent program and the CAP program. We went from expenses of $80 to $100 million a year down to $15 to $16 million a year because of Medicaid expansion. And so when that happened, when those costs went down to the extent that they did, the legislature looked at that and they said, well, we really don't need to have this CAP program anymore. We shouldn't be requiring the counties to cover indigent medical expenses, because theoretically everyone in Idaho has access either to private insurance or Medicaid now. And so as a result of that, in 2022, the legislature repealed the CAP program and the county medically indigent program. I was speaking a lot yesterday, and so my voice is a little scratchy. And I also think some of my allergies are kicking in. I'm from Boise. We've got different pollens down there than you've got up here. And so we had this repeal of the county, again, medically indigent program that kind of got counties out of the business of covering medical expenses. The state got out of the business with the repeal of the CAP program. And as part of that, there was essentially a transfer of responsibilities. And so the legislature also, and the bill that did this was House Bill 316 in 2022. The legislature at that moment also said, health districts are a lot closer to the local communities. The state shouldn't have as much involvement or support in health districts. So we're going to remove the responsibility, the obligation of the state to fund health districts, and we're going to shift that to the counties. And so the idea was counties don't have to provide indigent medical services anymore. Let's have them use some of the savings from that to pay for public health. The reality when you talk about the budget impacts to counties is they varied across the state. Some areas, like in the Treasure Valley, it was a net savings to the county budget, not having to do the county indigent program. In other parts of the state, like in eastern Idaho and north Idaho, we saw the opposite to be true. They actually were paying out less in indigent medical claims than what the costs are to operate health districts. And I think there are a variety of reasons for that I'm really not going to go into, because that's not the reason we're here. But at the end of the day, that kind of brings us to where we're at right now. I will add that the legislature has made a couple of attempts over the last few sessions to impose work requirements. There was a waiver bill that, this goes back, I believe, it might have been 2020 when the first one was instituted. A waiver request was submitted and denied. Now there's a new administration, and so the legislature, and this is where I'll hand it over to Representative Redmond, introduced and passed the Medicaid Reform and Cost Containment Act to, again, shift the model for how those Medicaid dollars are managed, and also to explore once again seeking a waiver from the federal government to provide a requirement that an individual, if they're on Medicaid, that they're required to work. And I understand you were in D.C. last week, and so he has, I think, some helpful information on really where we're going with Medicaid and some of these health-based services that I think would provide some helpful insight into the discussion that we'll have here in a moment.
Thank you, Seth. I'm going to remain seating if I can because I'm going to be referencing some notes. But my name is Jordan Redmond. I serve as a state representative here in District 3. And I really appreciate the board looking into these kind of issues. I love seeing like a proactive board that are actually looking at how do we solve problems, how do we make Panhandle Health better. I know some of the board members, and I had a great meeting with the director the other day, and so I just appreciate all you and your service to this community. The good chairman asked me to come give a little insight into some of the things at the state level that we're working on and kind of what we did this last session, what we think we're going to see in the future. And my biggest goal being here today with all of you is I want to be a resource to you for on the state level. I want to make sure that I can answer questions and work with you all as best I can. I do serve on the Health and Welfare Committee as well as Environment, Energy, and Technology, which I would guess is the majority of legislation that you would see from the Panhandle Health District. So, as Seth alluded to, we did pass a bill this last year dealing with Medicaid. And one of the reasons for that is Medicaid in our state has, since I've been there, the Medicaid budget has been the largest budget our state's passed, and it's set a record each year. And I think a number of the legislators, including myself, don't believe that it's been run correctly. I think there's some issues with it. And so what we wanted to do this year was reform the program, make sure we can keep the program as that safety net for all the folks that need that in our state. And I think Panhandle Health probably plays a really critical role in that, and so that's why I appreciate this discussion. I'll kind of walk through some of the details of that House Bill 345, and then also I would like to throw the mic over to Mike Baker from Heritage Health because he was instrumental as a stakeholder in helping us craft the bill and also seeing how that bill is going to be implemented. One of the first key pieces of that bill was there's more legislative oversight. For so long, the Department of Health and Welfare has been able to make changes to the Medicaid program without any legislative oversight, and we felt like, unelected bureaucrats probably shouldn't be making major changes to a program that, it gets voted on each year by elected officials. As well as the Department of Health and Welfare will be meeting with a separate panel called the Medicaid Review Panel, which I also sit on. We'll get regular updates on that as we roll out some of the implementation of House Bill 345. So I believe on the 23rd, I'll be back down in Boise meeting with that Medicaid review panel. As Seth mentioned, the work requirement for the Medicaid expansion. So the Medicaid expansion program is just for the able-bodied adults. And so that's what we're looking at this work requirement. It's 20 hours minimum per week for either working, volunteering, or doing some sort of education or study program. And again, that's for the able-bodied folks, right? There's a number of exclusions on there for folks that are medically unfit, for a parent or caretaker of a dependent. We tried to make it as broad as possible to ensure that we're trying to really speak to exactly what we want, and that's, Medicaid expansion passed for the working poor, and so we want to have that in place. In my meetings in D.C., I know that the feds are looking at that nationally. I believe theirs will be a little bit more restrictive than what we passed in Idaho, from what I've heard. But again, that's Congress working, so who knows what that will look like. I think part of that, too, is we heard a little bit about the mental health epidemic in our country, and I think that people being involved in community, whether that's volunteering, working, or studying, I think that's healthy. I think being around people is really good, and I think that can be one of those solutions. It's not a silver bullet by any means, but I think it can help. We also looked to institute managed care throughout the entire Medicaid program. We have a number of managed care organizations working currently in our state, but we wanted to take a holistic approach. And what that looks like is I think what we'll see is better cost containment. I'm not saying we're going to see a cost decrease, but we'll have better cost containment, so we're not seeing those 16% increases. We can contain that through the contract, and that's something that the Medicaid Review Panel will work on. We can dictate exactly what that contract looks like. Whereas right now we have no control over that. We have to pay those Medicaid bills. So when we get that bill, we have to pay that bill. And so that's why we have seen 16% increases, 11% increases, whereas now we can have a third party assume some of that risk. We can say we're not going to pay anything over a 4% increase, and anything after that, they end up paying. So it will give us better cost containment within the Medicaid population. We also, one of the biggest issues that I saw with the Medicaid program is we have something called an improper payment. And in Idaho, we have best estimate is about 20% of improper payment. This is over a $5 billion budget. We have over $1 billion being spent improperly. One of those biggest issues is probably in eligibility. And so with that, we wanted to see, make sure that we're if you qualify for Medicaid, making sure you really do qualify for Medicaid. So we're doing, instead of annual reviews, biannual reviews on qualifications, as well as we used to do an auto renewal. We suspended that and made sure that we actually want to verify that people should be on there, because again, we have a finite amount of resources. We want to make sure that that care is going to those that truly need it. Some of the other reforms that we worked on was better reimbursements for some of the rural emergency areas. What we saw, because we do have a very rural state, is that some of those rural hospitals were really struggling to get by because they weren't having probably as good payments as some of the other larger organizations. So we wanted to have better reimbursement parity for some of those rural emergency hospitals, as well as the FQHCs. I believe that the FQHCs are that true safety net for this population. I think they do a very good job. A number of them do. Again, like I said, I worked with Mike pretty closely on a lot of this legislation, and they were really struggling under the previous program, which was the value care organizations. There were several of them that did not know if they were going to be able to keep their doors open, and so we allowed for immediate relief off of that program for the FQHCs. And I think, again, I think Panhandle Health probably plays a really big role in this as well. I think it's really encouraging that you guys are discussing that and seeing what that role looks like. This was a holistic reform bill, and I think the whole thought was, how do we make sure to run a better program, have better accountability in that program so that we can keep the program for those that truly need it, because we do know we need some sort of safety net program for those folks in need. Mike, do you want to say anything about 345 or?
Yeah, healthcare is really challenging. So I work at Heritage Health. I'm the CEO there. Oh, do you want me to use that one or this one? Sorry. Both. Got it. Sorry, my name's Mike Baker. I'm the CEO at Heritage Health. We are a federally qualified health center. And for those that may not know that, federally qualified health centers started back in the 60s, back on the war on poverty, and I actually love it. It was sort of a way for the federal government saying, look, we probably might not do healthcare very well, but we recognize that there's a financial implication in providing healthcare in this country. So they set up this program where it's a really great match. It's federal dollars that come in that have local control. So my board of directors, they have to be at least 51% of our board of directors have to be patients of the health center. So it's doctors, it's patients, and it's administrators all working together to try to build a better healthcare system. And we're open to anybody. We have a sliding fee scale. So we are established as a safety net provider. The primary focus was taking care of people that did not have insurance. What happened along the way is that the Medicaid programs, Medicare programs were established, and the payment mechanisms for those started become challenging for private payers. And so access is probably the number one question we're all talking about today, is just access to care. Well, people weren't able to access in a private system, so started coming into community health centers. So then we became the safety net for underinsured or uninsured patients that were working through the system. As healthcare providers, we are just here to take care of you. Our mission at Heritage Health is to improve life. I was talking to somebody in the break. I grew up watching MASH. I don't know if that's good or bad, but there was that red cross on all the tents and all the Jeeps, and like everybody's out there. There's a war happening, and we could put it today. There's a war happening out there. And there's these hot button issues that flare everybody up into just this sort of war state. And healthcare providers, through the COVID years and through everything that was happening, just trying to keep people alive and do our work. That's what we do. We need to be engaged in the larger conversations, but we need to find a way to just deliver healthcare in this very complex system. So House Bill 345 was really looking at the funding mechanism for health centers for covering patients with Medicaid. It's a critical resource for our community. We need to find a better way to do it. And so looking at healthcare from a more holistic approach, looking at it. So at we have our Center for Healthy Living that we just established. It's all about looking at behavioral health, medical, dental, pharmacy, putting it all together under one roof, and then really looking at how do we add physical activity, nutrition, one of those holistic approaches that come into it. House Bill 345 opens the door for us to have more of those conversations in a managed care environment where we can say, what are the real components that are driving healthcare issues and how do we actually make an impact? And so I am an optimist, so I am really excited about the conversation we're having in the community. We've had great conversations with Eric before, with Jamie at Kootenai Health, with Rick Rasmussen. We are all engaged in a conversation about what are our strengths? What are the things that I can do really well as a community health center? What are the things that public health can do very well? What does Kootenai Health do well? What's Northwest Specialty? We're blessed to have Kootenai Health up in Bonner County, Bonner, and then Mariman Health, which is shown, and then Chaz has clinics that cover Lewiston, and so we're really lucky to have these great healthcare systems that are just designed to take care of people. But as Dr. Fletcher talked about with me on the phone, what is the opportunity to do this better? And I love that we should always be having that conversation. And let's grow that. Let's grab that energy and do it better. I know that there are things I can do better at Heritage Health. We are trying so hard to do everything we can, but we cannot take care of everybody in this community. It doesn't work. The primary challenge we're facing really is around healthcare providers, recruiting healthcare providers to Idaho, growing our own base. We need to have that. If you listen to Sam Wolkenauer, the economist here in town, I love when he talks. He's like, listen, this is a math problem. We just don't have enough people to take care of people. So have more babies and let's figure out how to live longer, do these things, right? And that's the work of community health centers. So it takes a partnership between public health, between community health centers, with the community, with the legislature. We've had some incredible conversations about what healthcare can look like, but it also requires some of us, we'll have to kind of put our guard down a little bit and say, yeah, we can lob grenades. It's really easy to say, I hate you because you have that stance on that one thing. Well, that's going to shut down the conversation. We're not going to get there. Maybe we don't agree on one particular issue, but there's 99 others that we can find agreement on. And so let's build from that and then at some point create that flexibility in there to say, hey, we don't agree on that, but that's okay. And that's where personal choice comes in. We can find that balance. And so that's what I appreciate about the relationships that we have in our community. We're able to have those conversations, and I appreciate the passion that so many people have about trying to change the healthcare system. Let's engage that, but let's engage that in a way that builds rather than tears people down.
Yeah, and I couldn't agree more. I think that's why I really do applaud this board for having this discussion, because I think there is probably some really good paths forward that you all can come to those solutions on. So I was in D.C. last week meeting with the President's domestic policy team, and I'll be heading back there a little bit throughout the summer as well, and kind of getting a little idea on some of the things that they're doing with in the healthcare world, as well as a number of other issues. In this reconciliation bill, they really are looking at those work requirements for able-bodied adults on the Medicaid expansion population. They're actually looking at, obviously there's a percentage that the federal government pays and then the states pay in expansion, right? And so, and Medicaid in general. They are looking at tweaking that a little bit. I don't know if that one is as feasible as some of the other thoughts that they've had. I think it's going to be difficult for them really to do that. But the improper payment is probably the largest piece for them, because they do see the amount of waste, fraud, waste, and abuse that they really want to tackle. And I think that's, I think we all should agree with that, right? Taxpayer dollars shouldn't be going to fraud, waste, and abuse. So those are the three key elements that I think they're looking at right now. Another piece of kind of the federal side of things, our Idaho Department of Health and Welfare director recently was nominated for a deputy secretary under Bobby Kennedy in HHS. And so he's been an incredible resource to Idaho, but now he is moving on to the federal level, and I think he'll be a great advocate for us here in Idaho on a lot of the health-related issues. So yeah, that's kind of a little update. So happy to take any questions or throw it back to Seth.
Can you talk about any other changes that might affect Panhandle Health District or go along with the fact of, Bobby Kennedy's very, very much on prevention and health. Was there anything that might be passed down to the states?
Yeah, I think there probably is a lot. I think, sorry. She was asking if Bobby Kennedy has some other health initiatives. Is there anything that's going to be passed down to the states? I think right now that federal administration as well as Kennedy is really looking at the states to kind of take the lead rather than kind of pushing stuff top down. So we did pass the SNAP benefits, so no soda and candy on SNAP, right? So I think things like that. They're looking at nutrition. They are also looking at vaccinations and kind of the testing behind those. So there's a number of health initiatives that I think they're looking at, but I think this administration is probably leaning more on the states making those determinations rather than doing more holistic throughout the federal government. So, all right, I'll give it back to Seth.
Okay, I don't see any other questions. Where'd the other microphone end up? Right there, I think. What's that? Yeah, well, I think what we're going to do, I'm going to throw a little bit of an audible here. I'm going to transition a little bit, and we're going to talk about strategic planning and go through a SWOT analysis as part of this discussion before we have the comment section. And I want to talk a little bit about strategic planning. I think some of you have likely undertaken a facilitated strategic planning session before. If not, it really is an important part of organizational leadership in ensuring that what you're doing aligns with your purposes. And so when we talk about strategic planning, there are a number of components that are critical to having a strategic plan, an actionable plan. First and foremost, you need to look at your organizational structure. How are you organized? What are your governing documents? And it's easy when you're dealing with a governmental entity because your governing documents are set forth in to some extent, depending on the structure of the government, it could be in the Constitution. When you're talking about public health districts, the parameters that are set forth, how you operate, it's all set forth in Idaho Code, right, in Title 39. And so you have at your disposal the required services, the organizational structure, the funding structure of a public health district. So that piece is a little easier because all of that is known and it's set and it's established by the legislature. When we talk about an organization or a strategic plan, there are some key elements of that each organization really needs to have to be successful. And it really starts with what is your organization's mission? What were you created to do? What is your vision that accompanies that mission? What do you want to become as an organization? Again, within that context of what the statute allows you to do. And lastly, what are your values? How are you going to go about, executing that vision, following your mission? And those are all really key and critical components. Now, we're not going to spend our time today talking a lot about that, but I did jump on your website, and you do have a mission statement. And that provides important context to how you deliver your services, why you're doing what you're doing. And it's very succinct. It's important when you have a mission statement that those statements are succinct. You don't want to get too flowery or have them ramble on. And there are really 3 items that are bolded that stand out. But the mission statement of the health district is to prevent disease, disability, premature death, to promote health lifestyles, and to protect the health and quality of the environment. I mean, it sums up, I think, in a pretty succinct manner what health districts are created to do, right? And so it aligns with what the statute is, that you're here to prevent disease and the spread of diseases. You're here to promote healthy lifestyles, and I think that discussion has come up quite a bit with this group. And then protect the health of the environment and quality of life in your community. Now, it was my understanding in coming into this that, the primary focus is on clinical services and clinical health. And so we're not really going to delve into the, protection of environmental health and that aspect of sewers and septics and water quality and food inspections and whatnot. We're here primarily to talk a little bit about clinical services and what you do now, where you're going down the road, and really what is the appropriate thing to do. And really at the onset of really assessing what the district is going to look like down the road, what those clinical services are, and I think Dr. Johnson really did a good job of really hitting the point, making the point that you're not here to scrap clinical services, right? You're here to find out ways you can provide those services in a better manner or a more efficient manner, to better partner with the private sector and nonprofit communities, is to take a look at what you're doing now and how can you improve upon that. And a key component of that is a SWOT analysis. For those of you that aren't familiar with a SWOT analysis, SWOT stands for strengths, weaknesses, opportunities, and threats. SWOT. Now, there are various components to a SWOT analysis. Your strengths and your weaknesses, those are all internal to the organization. When you talk about opportunities and threats, that's all external to the organization. And so when you talk about your strengths as an organization, again, that's internal. That is what you do well. What's going well. It might include the resources that you have available, whether those are financial resources, whether it's organizational structure. It could be the staff that you have that execute really your strategic plan and do the day-to-day actionable items that the district does, right? And so those are all things, again, internal, inside of the organizational structure. And again, think of those strengths as the resources you have and how you do it and doing it well. When we talk about weaknesses, again, that is internal to the organization. We're talking about some of the challenges or struggles that you might have as an organization. It sounds like turnover could be potentially one of those areas, right? It's a very competitive job market, and you've got some vacancies right now, right? And so, that's an example of internally something that could be perceived as an internal weakness. A weakness is an area that you might need to improve upon, right? Maybe there is a public relations communications piece of this if there's not confidence in the health district, for example. And it could be also another common weakness. And again, I'm not saying that these are the weaknesses of the group. That's what we're going to do with you guys is have that conversation and identify those things. It may be budgetary as well. You may not have the financial resources necessary to carry out your goals and objectives. And so that could be perceived as a weakness from the organization. So again, when you're thinking about your strengths and you're thinking about weaknesses, you're thinking of those things that are internal to the organization of Panhandle District Health. Now, we start talking about opportunities and threats. Again, those are items that are external to the health district, and they're also things that are largely outside of your control. So you can control your strengths and weaknesses because that's internal. What you can't control is what happens outside of the district, outside of your operations, outside of your organization, outside of your budget, right? When we talk about opportunities, those are things that may come up that you could potentially assist with, again, as long as it fits within your mission, your organizational structure, and your governing documents. So it's an area that you might be able to improve upon. And there's been a lot of discussion about partnerships with the federally qualified hospitals that are out there. With hospital, I guess you don't have a hospital district here anymore. You've got a nonprofit hospital, but what are some of those opportunities to partner and work together, right? Those are opportunities that the board could potentially take advantage of in better delivering services or meeting the needs of the community. And then when we talk about threats, again, externally, what are things that could potentially harm the health district, right? Are there things, again, outside of your control? let's say that there's an economic downturn, for example. People are all of a sudden out of work. They need services. Are you in a position to be able to address that, right? That's something that's outside of your control. Now, again, this caveat, my background and experience is in county governance. It's not so much in public health or in public health districts. So there's a lot that I don't know about public health districts and what public health districts do. And so I guess a question for Director Kettner, do you guys receive Medicaid payments as a health district? Okay. And so, when you talk about potential threats too, if Medicaid payments, reimbursements provide a revenue stream, what happens if Congress decides to cut funding for Medicaid, right? I mean, some of the numbers that have been thrown around recently were, upwards of $600 million or $1 billion in cuts, right? And so that's a potential external threat. For example, that, there's not those resources coming in to meet those service needs. What do you do in that situation when there's still a service need, but there aren't the financial resources to do it? There could be, and when we think of threats, it doesn't necessarily have to be perceived as a bad thing. But when you deal with the legislature, will the legislature change laws that actually change what you do as a health district? If the legislature were to, they could potentially say, you know what? This last year with swimming pools, right? Municipal pools, the legislature said we're not gonna regulate in that area, right? And I know that was I don't know if it was contentious up here with this health district, but I know in some of the health districts they struggled with that, right? That's out of your control, right? The legislature gets to set the terms and conditions under which you operate as a health district, and so you're subject to what the legislature enacts as laws. You can try to forecast what might happen, but again, it's kind of outside of your purview. So I think that's a good example of really what goes into this SWOT analysis. Now, why is a SWOT analysis useful? One, it can help you find areas where maybe you're veering afield of what your mission is or what your purpose is as an organization. It can point out really where your strengths are. Again, if we're talking about a strength analysis, if you have a number of strengths, really, that should be areas that you continue focusing on because you're doing those things well. Another key component of this is goal setting, and we're not going to discuss setting of goals at this meeting. That's for a future meeting down the road for the board to take into consideration. But once you've developed your strategic plan and your SWOT analysis, you now have to find out or devise a plan as to how you're going to implement and execute that plan. And that comes in setting goals and objectives and tasks and standards. And a SWOT analysis provides really a critical piece of that because it lets you know where you need to improve and whatnot. And so that's why we'll be having this conversation this morning. I've told a number of the county folks that are here, and I've mentioned this to Dr. Fletcher as well. Tomorrow's Mother's Day. I do need to be home for that. I will be in trouble if not. And so I do, and I apologize for this, but I do have a hard stop time of 1 o'clock where I've got to hit the road and get to the airport to catch a flight home so I can be there tomorrow. And so I just want to use that caveat as well. But really what we want to do now with the board members who are here and the county officials is really undertake an abbreviated SWOT analysis. So this will be an interactive activity, and really what we're trying to get at, again, are what are Panhandle District Health's strengths, what are its weaknesses, what are the opportunities that you have, and what are some of the external threats. And I've got this giant Post-it note that we'll use for this. Typically, when I facilitate a session like this, it's with a much larger group. For example, when I was with all the public health districts, what we did is we broke people down into smaller groups for some small group work. We already have a pretty small group with our officials that are here. So I don't see the need to really break it down further, and so we'll just work with the group here. And again, we're going to talk about your strengths to start with. And so what I'd like to do is, give you a few moments to internalize this, and you likely have done that already. So I'll give you a couple minutes to think, and what we'll do is we'll start writing down some of the things that come to mind as it relates to the strengths of Panhandle District Health. So I'll give you a moment as I jot something down here. And for the benefit of everybody in the room, I'm going to ask that when you make a comment, you use a microphone so everyone can hear it. So who wants to lead off? And I'm going to give this to you. You got to give me a second so I can get back to write something down. All right, Commissioner Korn.
So I think one of the Panhandle Health District strengths is that they're already established. You guys have already got the ball rolling, obviously, for many years now. You understand how it all works, billing and all that. So I think being established is a huge strength.
Okay, so I'm going to write down it's already established. I'm going to tie that to organizational structure so you have everything in place. Okay, other thoughts? What else comes to mind? Okay, Peggy, go ahead.
Along those lines would be that we do have a presence in every single county.
Okay, other thoughts? Don't all jump at once. Tim?
Glenn stole mine.
Okay. Glenn?
I think we've got good personnel who are well-trained, and they've got good means of communications. They've got computer systems that can help them to manage their workload, et cetera, et cetera. So
Okay.
I think those are some strengths.
So most of the board members know this, but a lot of the other people don't know this. I did work for Panhandle for many, many years, and I worked in all the counties, but predominantly I worked in Hayden once a week, and I worked in Shoshone once a week, and I worked in Benewah County. And so I have this long historical perspective of Panhandle Health, and clinical services are very near and dear to my heart. But we have always, there's been some standard services like immunizations, family planning. But what I have seen with clinical services over a long period of time is how we have changed those depending on what the need was in the community. For example, before there was Heritage Health, there was Journey Clinic before Heritage, and they actually, came to Panhandle Health and provided services there because Panhandle Health at that time did not do primary care. So I think that's a huge strength, that involvement and working with other partners.
Okay. Commissioner Duncan? All out on everybody.
Sure. I think they're uniquely set up to be able to pivot. And government should be reactionary, because sometimes if you're too proactive, then you spend a lot of tax dollars for something that doesn't come about. So I think we're in a good position right now. We talked earlier about how, the numbers are changing. So now we're in a position where, okay, we can pivot. Maybe it's more education that, hey, we offer primary health care that, niche, because in some of the public comments, that's what it was. You have individuals who are receiving primary health care, and they don't want to see the clinical services go away. So I think the ability to pivot is a big strength at this point.
Okay. Commissioner Eberline?
Well, Commissioner Corn said it well to the point.
Okay. Fair enough. Dr. Fletcher, you're on the board. Do you have any, what's your perspective? What is a strength of Panhandle District Health?
Well, I think I'm in agreement with all of the previous comments. Being established and having a name and having a brand is vitally important. I mean, in any industry, having brand, Coca-Cola, whatever, is much of the objective. So while that's a strength, we need to not waste that goodwill. Okay. So I would say branding is a strength, but with a caution.
Okay. Any other items that, so let me read through what I've jotted down here, and then we'll see if there are other pieces. So again, we've got an established organization with a structure in place that's able to deliver the services. There's a presence throughout the district. Each county has an office and space for utilization. There are well-trained, good staff. You have IT resources in place that can lead to efficiency and whatnot. The next two, I think, are very similar: adaptable to community needs and able to pivot when there are new needs in the community, or when the community starts to perhaps want to go in a little different direction with the types of services, and then using the brand for good. Is there anything else that you feel should be added to a potential list of strengths?
I think one thing that both Commissioner Duncan and Board Member mentioned was being nimble. They can pivot, they can react to changes, and so I think that was helpful.
Seth, could I add one other thing that I think is
Absolutely,
and I think it's reflective of the legislative intent of health districts, is the way that they're devised and the way that they're funded. It allows for services through uniform services through all 5 counties that the smaller counties otherwise would not be able to individually afford. And in an extension of that, it provides a depth too. So while we do have individual folks that are working in outlying counties, instead of them being one-off, there's a depth of expertise, and I'm drawing off of environmental health services, to really provide the best answer and efficient delivery, program delivery.
Okay. Any other perspectives from staff? Mike, did you have something you wanted to add?
I do. I wanted to give an example of the strength. So when a while ago when I was working with Laura Whalen, one of the community health assessments really identified behavioral health as a significant issue, especially those particulars. We had high rates of suicide, continue to have that. But Heritage Health, Panhandle Health, Kootenai Health, we all came together and worked really hard to come up with a solution, which ultimately resulted in the crisis center that is now here and active in the community. And while it's not a perfect solution, it was incredible to watch the relationships that were built as we were tackling a community project. So I think it's an incredible strength that Panhandle Health can be that convener as well and help bring people together for solutions.
Yes. Oh, is he? Okay. Commissioner Domke, are you able to, do you have a microphone to where you could provide your perspective on the strengths of the Panhandle Health District?
I do, thank you. And I don't know that I have anything different to offer. I appreciate what's been said so far. I think it's pertinent.
Okay. So we're going to pivot then and discuss weaknesses. And so while you guys are thinking and internalizing that, I'm going to put this up on the wall for an activity in a moment.
Are you ready?
I'm ready.
Okay. I kind of have two. One would be just the lack of knowledge. I didn't actually know that you could go to Panhandle Health for a primary care service and just use it that way. The other thing is lack of trust just because of what had happened in 2020.
Okay. Yes.
I think one of the weaknesses is not reaching the people and that know what all the services that PhD put out there. We need to get the word out better.
I'm going to keep that one with lack of knowledge of services. I think that's in alignment there. Peggy? Weaknesses. Sorry.
Staffing for sure. Every healthcare agency is struggling with the nursing shortage. So staffing, and I think not only in, like with nurses, it's clerical, it's everyone.
Okay.
So staffing for sure.
Glenn?
The things I was going to say have been said, other than, yes, we've got to keep up with the job market as far as qualified nurses to staff the different counties, or to be able to travel and staff them with properly trained medical personnel would be my input. Also, I think the communications or public awareness, but that takes funds as well. So, can we do public service announcements with the local radio stations, in the newspapers, et cetera, to get the word out that these services are available to our population? So.
Okay. Commissioner Eberline.
Well, without being skeptical, I am skeptical when it comes to medical stuff. And I want to really have a good handle on it when I'm needing medical care. Otherwise, I'm very skeptical.
Dr. Fletcher?
Help you there? I want to pick up on your theme, and if I may, sort of, I see as a weakness that Panhandle Health, as well as, and again, I don't want to make this personal, folks. It's not you. It's every public health entity in America follows the program of the federal government. Okay, that's, for lack of a better word, I'm going to call it cartel medicine. NIH, CDC, FDA, all right? As long as you follow the program of cartel medicine, we're going to get sicker. We're not helping ourselves. It has nothing to do with intentionality. The nurses are wonderful. Their hearts are in the right place. but they're following a program as developed by people, by bureaucrats in Washington, D.C., who have motives that have been derailed. We're not performing the appropriate style of medicine that promotes genuine health. And as long as Panhandle Health, and as long as every other health district in America follows the program, we're not helping the citizenry. So,
Okay.
the weakness is you're following cartel medicine.
I'm gonna not push back on what you said, but the timing of what you said. I think that likely fits more within, because it's external, more of a threat from outside.
Okay.
Would you guys?
As you wish.
Yeah. So hold that thought for when we get to the threats. So Commissioner Korn.
So most of my opinions have already been voiced. Lack of trust, and that's not just for Panhandle Health District, but the medical field in general. Communications was a great thing, I believe, and the lack of preventative medicine.
So I guess I'll give staff an opportunity to kind of weigh in on what you think a weakness is. Oh, yes, Dr. Johnson, I'm sorry.
It's really interesting because there's several interconnections here with the terminology, but a North Idaho person, in general, as we all know, is very, very has a tendency they live here because they want privacy, they want preservation of their family, protection, and that communication issue of trust. I mean, the trust is a multifactorial issue, and I mean, for example, and it's related to that, as Tom mentioned that the WIC program, and Eric and I were talking about this. The WIC program, for example, when they offer free food, you have to buy these particular brands from these particular companies that are not the healthiest, and they don't provide it any other way. If you don't buy that, you don't buy food. And it sounds great to be offering food, but it's like they're not the healthiest. And so there's a restriction there. So that's why I lean back more towards somehow I think it's a weakness that we don't have the local, somehow in some way more of a local influence, because we have that local influence, we would increase our trust. If we'd increase the trust, and trust is going to take communication, it's going to take clarity, it's going to take options. I mean, I think it's an absolutely fundamental issue, and everyone sort of said that, but I don't know, there's some missing piece there that I don't think we're clarifying enough, is my point.
Perfect.
Thanks, Seth. I think, listening to the comments on the weaknesses from the involved individuals, I think that a significant weakness, and it's on mind to shoulder, is education to our board, to our commissioners, to our community on the services that we provide, how we're funded, how the programs are implemented, because some of the things that I've heard show that we haven't done an effective job of bringing that information to individual commissioners and to board members. So I would say that that's something that we definitely need to do a better job on.
Okay. Did I hear that Commissioner Domke also? Go ahead, Commissioner.
Thank you, Seth. I just wanted to mention, and I know this is sort of a piggyback, but I'm trying to come at it from a slightly different angle of what Dr. Fletcher mentioned. To me, it's about taking leadership. I believe that there's a lack in our seeing ourselves as leaders in our local community for healthcare, instead of just becoming sort of the vending machine for the state and federal government. We should be looking for opportunities to lead discussions and lead actions wherever we have the authority to do so, because the local grassroots level is the most important. and it's what everything else is built on. So I would say that we need to change our perspective. So I think the weakness is we don't see ourselves as being leaders. We see ourselves as being dependent on the state and federal guidance. But I think we can identify areas where that's not the case, and we can truly step up as leaders.
I'm out of room. Thank you. So I'm going to go through here quickly and tick off, and I tried to lump some of these together. So lack of knowledge of services, lack of trust, and I put post-COVID in parentheses there, staffing shortages, turnover, public communications, lack of preventative medicine, local influence control, board education, and so perhaps the board isn't as knowledgeable of services, and so we've got kind of two target audience. You've got the public, but you've also got the board, and so board education, and then board leadership. Too much reliance on others, and I think that ties in with your comment earlier. Anything else missing from that? Okay, we're going to shift to opportunities, and again, I'm going to give you a few moments to internally think about that as I put this on the wall. I'm ready, and because I forgot about Dr. Johnson, and thanks for reminding me, well, he's talking now. Go ahead, Commissioner Duncan.
All right. I think for opportunities, we do have people starting to recognize that they are not well and that they would like to get well. And I think with this current administration and what Kennedy is bringing to the attention of the nation, I think will be helpful. So, plus the lack of primary care and health care in general. Those are the two opportunities.
Okay, Dr. Johnson, I apologize for skipping you the first round. What's your thought? What's an opportunity for the health district?
Emphasis thank you. Proactive medicine is better than reactive medicine. That established medicine has an extreme emphasis on, wow, we've got these new treatments, and there should be an extreme emphasis on, wow, this particular activity, this particular dietary program, this is preventing disease and reducing costs, and that's a tremendous opportunity that everyone kind of says, well, we should eat healthy, but then that's defined differently by about 50 different people, and so I think we could do a better job of really encouraging and being outstanding in that prevention realm, and moving forward, we'd save healthcare costs across the board.
Okay, Commissioner Bertling, and then we'll jump down to Commissioner Korn.
Okay, to piggyback on what Dr. Johnson said, we have an opportunity to really look at offering up different programs to address that, and that's where I think the opportunity.
Okay, Commissioner Korn.
So I think we're looking at a huge opportunity right now if we were to actually bring back to the table and discuss informed consent. It's something that probably is not being done around the nation, and why not let North Idaho lead the way on that? So along with that is truth and transparency.
You see, Commissioner Domke, go ahead.
This may be a little redundant, but I believe the word I want to focus on is trust. We have an opportunity to build trust with the community. And I agree with Commissioner Korn that one way in which we do that is to tackle the challenging issue of informed consent.
Okay. Yes, Dr. Fletcher.
One could argue that medicine has lost its way. Again, we're sicker, living shorter lives, etc. This may be an opportunity at a local level to assume leadership. Let's show Washington, D.C. how to do it.
Any other thoughts? We've got three that haven't weighed in yet.
I think just the discussion that's taken place here today with partners, getting ahead of the fact, like we know there's probably going to be more uninsured out there, but working on a plan that's going to work for each community, because each community and county in North Idaho are totally different from one another as far as I just look at, like with the federally qualified health clinics, if you're in Avery, it's 60 miles to get to Plummer. So I think there's a lot of opportunity by working together to get ahead of thinking about what are the needs that are going to be out there.
Commissioner Eberlein, did you have your hand up?
Some years ago, I started looking at Dr. Kennedy's experiments and what was taking place in Africa. I think if you really dive into that, you'll be shocked about, because the Nazis weren't as bad as they were.
Lynn?
As far as opportunities, I think technology, artificial intelligence is a big one. When I pose a question, to ChatGPT, will the changes proposed by the federal government increase the need for low-income population to seek free health care services? What was the reply? Yes. Proposed federal policy changes, depending on their nature, can increase the need, and it goes on and on. So it's a tool that I think we can take advantage of. You've got to verify their response. You can't let it control what you're doing, but it's a good resource, I think, for us to query, because they come up with all kinds of, it draws from the internet all kinds of ideas, latest technologies, latest techniques, those kinds of things that we could benefit from.
Staff perspectives?
I think the board and the commissioners provided a pretty good overview of that I do agree with. We are at our heart, at our core, we are prevention with the direction that the HHS is looking, at preventing chronic illness. I believe that we will be in a unique position for reasons discussed to help spearhead some of those efforts. I think partnerships are going to be important in how we do that. And I do think the trust is a core issue. My approach to that is we got to find issues that we can all rally around, that all of the communities can rally behind. And that's how we're going to best build trust in this post-COVID environment.
Okay, we had a few more on this one. I'm going to go through these and just make sure we're not missing anything. People recognize that they're not healthy and want to get well. Lack of primary care, proactive medicine care, preventative care. Again, some of these are fairly closely aligned. Programs to address gaps in preventative care, informed consent, truth, transparency, and building trust, assume local leadership, community partnerships targeted based on community needs in each county. And again, I think that's similar to what Director Kettner said in rallying communities behind a common goal, build consensus, and then use of technology tools and resources. Anything else from board members that you feel like we've missed that would be good to add, or do you think this is, yes?
If I could sum it up in one word, I would say trust.
Okay. That is a pretty prevailing theme in what's been discussed. Okay, start now thinking about threats. And again, these are things external to the board and Panhandle District Health. You guys ready? See, Commissioner Duncan's ready.
I suppose funding is going to be a big one.
Commissioner Corn?
Staffing, lack of staffing, being able to find staffing.
Microphone.
Oops. A potential threat is, again, almost kind of like a reactive pattern to the next pandemic. And I think there should be, if there's forethought and planning and positioning, it wouldn't have such a devastating hit. But they keep talking about, there's going to be any of a multitude of pandemics coming at any time, and that's always in the news. But there doesn't seem to be any, in essence, okay, this is where we did wrong here, let's do it differently in the future with the next big pandemic.
Thank you. Commissioner Domke, before I forget about you online.
Yes, I think the further erosion of public trust is a legitimate threat. And as was mentioned at some point previously, the potential reduction in federal and or state funding.
Dr. Fletcher?
I would just echo what I would echo with what Commissioner Donkey said. It would be a pity to squander your trust. It's a precious commodity. You lose it, you no longer have branding, you no longer have loyalty, your community ceases to follow you, respect you. Trust is, don't lose it.
Other thoughts, or Commissioner Corn?
Big Pharma, I think, is a threat. They've got a lot of money, which comes into lobbyists.
Okay. Glenn?
Using my technology, public health organizations face a wide range of threats. Number one, funding and resource limitations, budget cuts at the federal and state or local levels. Inconsistent funding makes it hard to maintain long-term programs or retain skilled staff. Dependency on grants. How dependent are we on federal or state grants? Political threats. Politicization of health policies. Legislation restricting authority of public health officials. Lawsuits or regulatory changes. And also workforce challenges. Burnout and turnover. Aging workforce. Lack of competitive salaries. Category 4, misinformation and public distrust. Health misinformation on social media undermines public guidance. Decreased public trust in government health agencies. Conspiracy theories targeting public health leadership. Number 5, emerging and re-emerging health threats. New infectious diseases, reemergence of preventable diseases, antibiotic resistance, and climate-related disease patterns. Number 6 was cybersecurity risks, data breaches of health information, ransomware attacks. Number 7, inequity and social determinants of health. Health disparities that strain public health systems, limited capacity to address root causes such as poverty, housing, education. So
in your words, what would you say is one thing that you think is a threat here?
I think, as has been stated, trust in the system, trust in the federal decisions, trust in the local decisions, our good old mask mandates. Yep, we should have responded quicker when it became obvious that the masks were not preventing the spread of this disease. So why are we insisting that people wear them?
Yeah.
Those kinds of things.
Okay. Peggy, did you have anything you wanted to add?
Great list, though. Great list.
Okay. Tim? Staff?
I think all of them were fairly well identified. I think the one that I heard several times is and the way I wrote it down was misperceptions. We are your local health department. I would say that certainly we follow guidance that we receive from Health and Human Services. But what I want to say is that why we have this group and all of our staff here involved is we are part of the local health department. We want to have conversations. We want to correct misunderstandings on what our goals are. And I would say during COVID, we lost a lot of trust. There are still a lot of folks that throw us in the same, lump us together with CDC and different other things that in many cases never happened here, or we try to work within the guidance that we were given to help the local community. And I want to continue, and that's a philosophy that's held by the entire executive staff here. So I believe we have a long way to go to rebuild trust, and I would like to make efforts to do just that.
Okay. So I'm going to try to summarize here what I've jotted down, and then if I'm missing anything, please point it out for me. So funding came up several times in a variety of ways, whether it be federal funds, state funds, grants, loss of local funds, lack of staffing shortages came up a number of times. One of the comments was a knee-jerk reaction to future pandemics, having a better response. Over and over, this notion of erosion of public trust in public health came up. Big pharma, federal, state legislation, regulation that may have impacts in the future on what public health districts do, misinformation, misperceptions, not understanding the purpose of Panhandle District Health or the services that are provided. Any other items?
So after hearing all those, I have kind of an afterthought, and it might be already wrapped up in one of those, but the threat of our state and federal governments as far as mandating to the local Panhandle Health districts what they need and what they need to do or what they don't need to do, such as what Dr. Duke brought up earlier about the next pandemic. So I do think that's a big threat about our state and federal governments dictating to our local districts and boards.
Yeah, I think that's a good thing to add. It's a little different than, legislation that might come. This is more of a direct mandate that you have to do this. Okay.
If I may say that, I think the Idaho legislature did a pretty good job of remedying anything like that from likely happening. I certainly defer to Representative Redmond on that.
Yeah. You have anything to add, or? Yeah. Yeah. Okay. Well, I'm going to put this on the board. Okay, so the next step that I'd like to do, and this will help to provide guidance for future discussion at future meetings that you have. I've got some stickers here, and this one I'm going to limit to the actual board members. Again, because this will frame how you'll engage in future conversations, how you'll seek public input in the future. I'm going to sneak out of here. Okay. What I would like you to do, I'm going to hand out, we had a lot of things that were added on the board, and it's important to be able to focus on really the core of what we've got posted there. And so I'm handing you some stickers. I'm giving you, well, there are quite a few stickers here, and so you can choose how, and I guess we'll have to figure out how to get feedback from Commissioner Domke at another date, but what I'd like the board members to do is use these stickers. You have quite a few of them, so you can weight things as you feel appropriate, or you could spread it out evenly across the items on the board. I'd like you to put a sticker on or around the strengths, weaknesses, opportunities, and threats that resonate most with you. And then what we'll do is we'll have that information. I'll leave that with staff so they have it, and you guys can use that potentially to shape future goals that you might set as a group, future items to discuss, future, again, meetings with the public. I think an important aspect of strategic planning, especially for governmental entities, and I am impressed that we've got the number of people that we have here. Too often when governing boards convene to have discussions, no one comes. And so I think public participation is a part of this. And I think as you guys go down the road over your next few meetings of discussing clinical services or whatever it may be, that it's important also to focus group with various community members and take feedback from the community and the public to make sure that there's alignment with what you perceive as strengths, weaknesses, opportunities, and threats with what the public perceives as strengths, weaknesses, and threats. Because again, as a governmental entity, health districts are structured a little different than the county or the city or the legislature, where the public has the direct means of voting. When we're dealing with public health districts, it's the Board of County Commissioners that appoints the representation, and so I don't want that to get lost in your discussions as well. So take a few moments to put your stickers up where you think it's appropriate.
Are the colors bleeding?
No. Nope, they're randomized from the package.
Let's screw this study up and we just put all our stickers on one thing.
You can't have that person back because what you do is you lose your voice. To do that public comment, is that?
Yeah, I mean, I know that these rules are, but they've really been traversed. And you commented on that at the end there. But it's possible to show them some logic.
Yeah.
And I'll shield you. I'll be your bodyguard. And I will, actually. If you let it happen, then if they ask a question, you don't have to mess with it. How's that? I'll make it a deal.
Yeah, perfect.
Yes, I'm ready. I'm not actually stealing more stuff. This was Commissioner Donkey. And he wanted me to stick stickers on for him, so I'm not cheating, okay?
Donkey input.
ChatGPT is crazy.
Yeah.
It's a good tool.
It really is.
You gotta verify some of it's independently.
Yeah, it's awesome. Well, we've still got a little more to go. So just for the public, we are going to wait a few minutes for others to come. And then I do want to engage with you guys a little bit too, because you've been so good. I don't? Is that? Oh, good. You guys have been very patient. And again, really appreciate you being here. Jumping jacks. I think we'll wait for Dr. Johnson to get back. I assume he is. Look.
He said he subcontracts with Spokane, but it's MIT. And he said the organization's been around for 30 years. So, interesting.
Yes.
I know. I'm definitely good. One of the gals sitting over there used to work with Kellogg, so. since she lives one direction and I live the other. One time, only one time, all the years of commuting, I was so tired of driving by the time I retired. But one time, you know, like when they talk about one time I showed up in Kellogg, and normally when I would walk in the door at Kellogg, we were waiting on this step. Because it was always quick and and I walked in, there was no one there. I'm like, what? I wasn't out, it was the only time it wasn't scheduled. I didn't have a clinic. I mean, yeah, which is pretty good for 20 years. Yeah. So, only did that one time. Yeah.
Oh, yeah, that's on the.
Well, it's too late.
Yeah, that's, I mean, my kids went there, they went there for well, baby checks, you know.
Yeah.
So for a while, the
Sorry
nurses
about
were,
that.
they do the Medicaid, they call the ESP, whatever, it was well child, basically. And then they switched it back to the nurse practitioner, so, you know, if we saw a kid that had a red ear and had an infection and needed an antibiotic, they could prescribe. I worked half the time as a nurse and half the time as a nurse practitioner. We used to go up to, have you been to Avery, Idaho? Okay, well, it's beautiful. We'd go up there twice a year to do well child clinic. And my volunteer, we'd have it at her house, and she would clear her husband's desk off. And we would set up the baby scale tubes, and she put a blanket out. We used to do well baby and WIC in all the church basements. So we did plumber.
You want to proceed with, would you like these to be read or?
No.
Okay.
No. This would take another session. I mean, there are folks who have actually delivered some thoughtful questions, but given the time constraints, and I want to give priority to the people who came and are sitting in the room, and I really want to appreciate them. Let me say, though, publicly, that these questions will be addressed in our board meetings. I can promise you that. And we'll do what we can to respond to them in a thoughtful manner, maybe even to the extent of writing back to the people who emailed us. How does that sound?
Sounds like a great plan.
Okay, thank you.
Okay. We do have a number of individuals that signed up indicating that they wish to provide public comment. And so the individuals that we have listed here, and I'm going to, do you want me to facilitate? Do you want me to turn it over to you? How do you want to handle this? Okay, so I'm going to turn it back over to the chair to take the lead in the open comment period.
Rick Kirshner.
Just sit here and do it.
Check. Well, hi, everybody. Thanks for your service. Thanks, Dr. Fletcher, for trying to do something worthwhile here. I'd like to start by asking if you can even imagine an Idaho where our poorest families find and enjoy locally grown farm fresh food, where children bursting with energy run faster than Wi-Fi, where our communities thrive in vibrant health, free from the shadow of chronic disease and disability. For me, it's not hard to imagine. I'm 75 years old, and I've been caring about and working to make America healthy again for my entire adult life. And here's why I'm asking you to imagine. The public's health is crumbling under the burden of processed foods, pharmaceuticals, and environmental toxins. I'm sure you've heard about the loss of vitality, though if you've not cared enough to address it, it bears repeating. The majority of our young men wouldn't qualify to serve in the military because of their poor physical condition. Type 2 diabetes is now in our elementary schools. Chronic diseases like heart disease and cancer are on the rise. As Dr. Fletcher noted, over 60% of our citizens struggle with chronic health issues. In what we claim to be the most advanced nation in the world, life expectancy is dropping faster than your interest in a much too long meeting. These aren't just statistics. These are our parents, our siblings, our kids. Public health data practically screams that it's our food, drug, and pest control system, ultra-processed junk, a pill for every ill, a shot for every chill, an ever more toxic environment, and public health guidelines that are stuck in the 80s. In the last election, Idahoans voted to make America healthy again, and you've got a trust problem that won't fix itself. Because of pandemic overreach and propaganda, public health now has a public reputation of shilling for industry and for captured agencies and cartel medicine with their clinical trial rigging and regulatory failure. The people have said enough is enough. This moment is an opportunity environment for meaningful change. The Maha movement, and it is a movement, has a foundational idea that does date back to the time of the father of medicine, Hippocrates. Good health starts with what we eat, how we move, and what's in our environment. In the country that made supersize into a verb, we need public health districts with teeth that target root causes and tear out weak policies. Instead of babysitting Big Pharma and Big Food's bottom line and turning to lawyers to avoid your responsibilities, you should be the architects of change, the guardians of the future, fierce in your commitment, data-driven and unapologetic. You could be heroes. Think about it. You shape policy, you educate the community, you influence budgets. You can advocate for clean air and water. You can run campaigns that link bad choices to chronic illness. You can save taxpayer money and people's lives. You can make healthy living cool again. We're at a tipping point. Chronic disease isn't fate or destiny. It's policy failure, and it can be fixed. If, like me, you believe that real health and vitality should be a birthright, not a luxury, you have a once-in-a-lifetime chance for public health to lead a revolution in wellness. I know some of you know this. All of you need to get on board with this or get out of the way. Thank you for your time. Now, imagine it was worth it.
Thank you. Karen Bloom.
Hi. Hi, my name is Karen Bloom. I'm with Johns Hopkins University and National Institutes of Health trained viral immunologist. I was also an epidemiologist with Panhandle Health, where I worked with the late Jeff Lee, who was a lifelong public health epidemiologist who had been with Panhandle Health since its very first district director. During the height of the COVID-19 pandemic, Jeff and I advised the PhD board, particularly Dr. Alan Banks, the former Bonner County representative, on evidence-based strategies to prevent virus spread and protect our communities. At the time, Dr. Banks dismissed masks, testings, and vaccines to curb community transmission. Well, I'm here today. He's not. Isn't it funny how little about public safety we can disclose in our conversations? Today, I want to address Dr. Fletcher's presentation. His distorted view of public health is nothing but a ruse to erode trust in science and confuse the public. Public health, more precisely, population health, is about well-being of entire communities. It ensures clean water, food safety, housing stability, emergency preparedness, vaccination access, and yes, equitable access to health care. Medicine, whether public or private, while important, focuses on individual diagnosis, treatment, and action a person can take to achieve better health outcomes. It is only but a small part of a larger system of public health and cannot substitute for a broader, coordinated community level of care. Let me remind you that PhD bears the shield of public health. Your mission is to protect the collective well-being of North Idaho. That means advocating for a model of community workers of care, prioritizing both clinical and social care, especially for those who are underserved, marginalized, or living in poverty. Dr. Fletcher has also referred to a failed healthcare model he worked with in Texas as a cautionary tale to downplay Medicaid expansion. But we should be learning from successes. Cities like Philadelphia, where Medicaid expansion led to integrated community health models that have improved care, built trust, cut hospitalizations by 65%, and saved Medicaid $2.47 for every dollar invested. That's both smart and efficient and demonstrates the kind of accountability I expect from our appointed and elected officials. Thank you.
Thank you. Pat Williams or?
Hi, I'm a retired Panhandle Health District employee. I worked for Family and Community Health for 25 years, and I'm here to advocate for clinical services. Family planning, women's health check, Komen, immunizations, STD treatments, and STD finding out is very important. I'm a resident of Shoshone County, and we have seen our number of days for nurses there cut even before I retired. So I do advocate for more staffing for each county. I've worked in Hayden, I've worked in Coeur d'Alene when Panhandle Health was in Coeur d'Alene, I worked in Shoshone County and a little bit in Benoit County, and I want to tell you, the people of our communities need Panhandle Health. Thank you.
Thank you. Dee Dee?
Hello. Thank you for holding this meeting. One thing that really strikes me is that we have, I think, 4 out of 15 commissioners represented. And that really bothers me. I hope the public remembers that when we go to the voting booth, because you guys are the ones that do the budgets. You're the ones who put people on this Panhandle Health Board. And so for the 4 that are represented, I really appreciate that, and that's noted. I'd like to also echo something that Dr. Kirshner talked about. Last weekend, I was fortunate to attend a Marine Corps League convention in Boise, and one of the things that came out was that the recruiter for Boise was present, and he told us that month they had 23 applicants to come into the Marine Corps. 3 of them qualified. There is so much mental health issues. All these kids are on antipsychotic drugs. They're 100 pounds overweight. There's just all kinds of problems. And so prevention is, I don't think we can stress that enough. as a retired nurse, I recently was an advocate and went into one of the Heritage Health clinics with a young woman on Medicaid, and I absolutely cannot say enough good stuff about what happened, what I observed firsthand. The young lady, it took less than a week for her to get an appointment. I didn't even have time to put my rear end in a chair by the time she was giving her stuff to fill out. We walked immediately back. We were put in a room. We were still filling out her intake paperwork when the nurse practitioner walked in. She was 100% appropriate. She took care of everything. Nothing was pushed on her. We weren't asked, do you have this? Have you done that? It was all about a focus on what she was there for, and referrals were made. I can't say enough good. So I would like to advocate that Panhandle Health get out of clinical medicine, give it to those who have the process worked out. Anywhere, you know, if Shoshone County doesn't have access to one of these other providers, then you might look at staying there. But for the people who've got that, I mean, they were moving meat, and I was so impressed. So what I would like to ask Panhandle Health to look at is, let's talk about prevention. So we talk about people need to know how to budget. Money's tight. Let's teach them how to make budgets and how to make their money go as far as it can go. Let's not only tell them that seed oils are bad, let's tell them what they are and why they're bad and how to avoid them and how to grow some food, how to store food appropriately. Let's help people know how to cook appropriately, how to be safe in managing the food that they feed their children and send to school with them. I just think that prevention's where it's at, and let's not double up the efforts of the people who are doing it right. Thank you very much.
Thank you. Julia? Oh, well, that's it. Okay. Well, thank you, public. Wanted to make sure that you souls that stayed as long as you did had an opportunity to express yourself. Oh, the public on Zoom? Oh, tell you what, public on Zoom, hang tight. I'm going to turn it back over to Seth so that he can conclude his component of the program. He has a flight to make, and I want to be respectful of his time. But those of you who are on Zoom, I promise you I'll stay, and you'll have your opportunity to speak, but I need to respect his time.
Thank you, Dr. Fletcher, and thank you everyone who participated in this. What I would suggest for next steps for the group, again, there's no action items on the agenda related to this, this portion of the meeting. I'm going to leave the sheets with staff so you have those and can record those. What I would do is at a subsequent meeting, I think it would be beneficial for the group to have further discussion on the items that are included here. I'll go through and summarize where the high points are before I sneak out of here, but potentially have those conversations to help guide additional discussions. I'll also add and I've shared this with Dr. Fletcher, and as I've talked with Director Kettner and some of my county commissioners that are involved with the district, there is a lot of uncertainty right now. There's uncertainty as to the availability of federal funds. There's uncertainty as it's related to regulations, what directions we might see taken at the federal level, but also at the state level. And so this will be something that evolves as you have your conversations, right? When you're undertaking a project like this, it's critical to really look at things from all angles, get perspectives from all constituents to ensure that, again, you're really reflective of what you're hearing from your communities, and those around you. And so I think what I've found most interesting in observing is there are some areas where there are clear areas of emphasis. There are other areas where it's more evenly distributed. And I think in particular when you look at strengths, there's a lot more of a distribution within each one as far as what you're doing well. And so really there's nothing that really stands out other than the one that received the most stickers is using the brand for good. And I think that's important to recognize as a district that you have been in place. You've been here since the 1970s. There's a lot of goodwill that has been built up over time with the services that have been delivered. And so find ways to maximize that. I think one of the unfortunate side effects of going through the pandemic is there was such a fixation on the clinical side of things that a number of the good things that happen within the health district are often lost. When you talk about the environmental health that's done, you guys have a pristine aquifer up here with the Rathdrum Aquifer and the Rathdrum Prairie. And it's also a sensitive aquifer, and it's because of some of the efforts through the health district, through their environmental programs, that you're able to preserve that water and the quality of that water in that aquifer, right? And so you have to look at it holistically as well as far as the Panhandle Health District. What are all these services that are being provided, and how do those services benefit the communities? Again, when I look at the list of weaknesses that came up, I do think that we can see some common themes in the next three sheets. There is a lot of focus on really that lack of trust that has given rise over the last really 5 years, and the implications that has in providing services. If we're talking about preventative health, that came up a lot. How do you reconcile that trust factor that may be missing with efforts to provide better preventative care and services for the public, so that they do say, look, this is a resource, how do we really tap into that? And then another popular one here, two others, lack of preventative medicine, which kind of gets to that same core, and then leadership almost over-relying on information from outside sources and from others. And so a couple things to think about there. When we look at the opportunities, again, trust is a prevailing theme here. How do we leverage the trust that we have in the community, maximize that, and apply that towards the various services that are provided here? Informed consent had a lot of stickers, and I know that's something that the board has been wrestling with, and I would concur. And I'm sorry, was your name Dee Dee? Would love it to have more county commissioners here to get their feedback and input, and so it might be worthwhile to do some outreach with those commissioners that aren't here to make sure that we're gathering feedback from them as well. And again, trust comes in quite a bit. It aligns with, there's quite a few stickers on truth, transparency, build trust. So again, that's an opportunity that this group, this organization really can take advantage of. And then it's interesting how you start to see these recurring themes, right? When we get to threats, again, we see this erosion of public trust come up, and the impact that has in your ability to provide services. Funding clearly is another item that is of utmost concern. I know that as I engage with counties around the state, in particular when we talk about public health funding, because districts are more and more reliant on counties for funds, that's a question that comes up all around the state, because when you look at counties and what counties do, they have a full suite of responsibilities, from the criminal justice system to, you look at law enforcement, maintenance of jails, district courts. I mean, there's a lot of mandated requirements that counties have, and they only have so much money to dedicate towards all of these services. So at what point does that become an issue when we talk about how we're funding public health districts? And again, misinformation came up with a number of dots. And we live in an interesting time. I grew up in the 80s and early to mid 90s, when I was a kid, and we didn't have this stuff, right? There was no social media. You went outside and sun was up in the summertime, you went out with your friends, you played, and then you came home when you got hungry, went back out, and then you came home when it was dark, right? I mean, that's how, and I think a lot of you probably were raised that way as well. We have so much information at our fingertips. That information can be used for good. That information can be used for bad. And so how do we leverage truthful information that's out there and make sure that we're relying upon respected sources, reliable sources in educating the public? Because once you start dealing and suffering from that erosion of trust, it can take some time to build that trust back. And part of the key to that is openness, transparency, and using fact-based information. And really a part of that is outreach to communities. I think one of the items that came up, first of mind for me, and again, I'm going to caveat this with, my background is in governance, organizational structure, organizational theory. It's not in public health. I'm not a public health expert. I was asked to come here to facilitate the discussion. And so I'm not here to opine on the pros and cons of public health and services. One of the things, though, that did stood out that I see around the state in my interactions with county commissioners and other county officials is each county and each community is different. And it's critical for governmental entities to be aware of that and recognize that maybe, and I think Shoshone County came up as an example, maybe service delivery looks a little different in Shoshone County than what it does in Kootenai County. I mean, in Kootenai County, you have an urban center here, lots of resources. You don't necessarily have that in Shoshone County or in Benewah County. Boundary County is very rural in nature. And so when the board is evaluating and looking at how you're going to go about delivering services, what services are provided, that's a key element of this, is understanding what the communities are and what those community needs are, because no two counties are the same in Idaho. It's something that I've observed. Every county structurally is the same, and every county is required to provide the same services, but the resources they have to provide those services are vastly different. But one of the interesting observations for me in looking at our counties, Clark County in eastern Idaho is our smallest county. Clark County has less than 800 residents. Yet Clark County is expected to provide the exact same services that Kootenai County provides, and Kootenai is pushing 200,000 people. Much more resources, right? And the irony in all of this is that Clark County is actually required to do more than Kootenai County. And the reason for that is no one has created a highway district in Clark County. Kootenai County, Commissioner Eberline, he doesn't have to necessarily, I'm sure you still get complaints about roads and how roads are maintained and plowed, but that's not the responsibility of the Kootenai County Board of Commissioners, because the residents of Kootenai County have created special purpose highway districts that take care of those roads. Clark County doesn't have that. They have to take care of all those roads, and they have lots of roads in Clark County. And so you really have to be adaptable to the needs of the counties and the constituents in those counties. And I appreciate that that was part of this conversation today. Really appreciate your time, your patience, and again, especially for the public. 5 of you, 6 of you in particular, have stuck through the entirety of the presentation today, and you should be commended for that. And really appreciate the opportunity to work with you guys. I think you're well on the way of having some good, productive, and fruitful conversations. And again, appreciate your patience and time today.
Well, thank you, Seth. Quite frankly, having Seth here was a privilege. His time is limited. He's all over the state, and it was great to have you. I suppose, is there anyone on the board seated here who has some comments, reflections? I'm going to turn it over to the remote public, and once they get going, we're going to be we're going to be dedicated to them. So Tim or Peggy or, I mean, any?
I think this meeting has been very useful, and good education in the things that we need to be aware of and that we need to be working on. That's why we have the next meeting and items that we should put on the agenda as well.
Thank you. In fact, you're the one who put that there. So
The follow-up. Now what?
Is
Yeah.
it an action item or are you just sort of FYI?
Uh,
It is
yeah.
an action item? Aha. Well, thank you. Do you want to make a motion?
Mr. Chairman, I would make a motion that we schedule another follow-up meeting in the next 2 months, I would say, about 45 days or so.
Can I make a friendly amendment to that? We get a new
Open to
board
suggestion.
member in July. So let's let that human being land on their feet, get adjusted.
Agreed.
And maybe have this meeting
Towards the end of July?
or August or September. Is that, I put
Yeah.
that out as a friendly amendment.
I would agree. So I'd make a motion that we schedule a follow-up meeting, probably end of August.
The August meeting?
Mhm.
Now, question.
Mhm.
Would this be a special meeting or these topics would be discussed deliberately in our normal board meeting?
I would say during our new normal board meeting,
Okay, fine.
we could
I'm good with that.
come up with an agenda.
I'll second.
Need a second?
I'll second.
We have a second. Any discussion? You seem to be that behind. Forget that. I'm, in my usual fashion, I'm going to take a vote in the negative. Are there any board members who object to the motion on the table? Hearing none, then that will be our follow-up. Thank you, Glenn. That was your point, and thank you for doing that. Any other comments of?
Thank you. I think this was a great, productive meeting. Thank you for putting this on for the commissioners and for the public. I appreciate the public coming down on a beautiful Saturday where the sun is shining out there and we should be in our gardens. But I want to thank Panhandle Health for putting this on and giving us all an opportunity to come to the table, literally. And thank you, Seth, for that awesome exercise. I think that really kind of pins down everyone's views and opinions on where we would like to see the direction of Panhandle Health going in the future. So thank you.
Okay. Any other comments, Mike? Or do? I am so sorry, Mark.
Well, I'm always skeptical about these kind of things, and some of these are great venues, but this is particularly invigorating, and I think it's going to be a very useful program to get people in here, and we can make things happen.
Well, I appreciate that that vote of confidence. You're slow on compliment, but you just gave us one. Thank you, sir. We appreciate it. Anyone else on this side of the table? Because I apologize. Okay, over here. You know, you got a good compliment there.
That was great, thank you. But I think it's, overall, that's the stuff that we really need to work in. Like, we have a lot of strengths in our community. I just wanted to point to one other example where we have had incredible success working together. So a few years before COVID, we started this project where we called it CrocRx. We were taking patients, it was all preventive focused work. We knew that if we could focus on patients with prediabetes, with mental health condition, if we can just do something different, we would see a change. So we would take patients out of the clinical setting, we would meet them at the Croc Center. We partnered, like Panhandle Health District brought down nutritionists that would teach classes alongside the medical providers from our teams. that project had so much energy. It was incredible to see what happened when the community came together and said, we can do something that's pretty simple: eat better, exercise, and be connected, right? Those three things. We had U of I do a preliminary research. We saw A1C scores dropping. We saw depression scores getting better. We had patients we had one patient, particular example, she hadn't left her home in 3 months. She came to this event, and then she started making friends. And it turned into this little small group thing, that there's a small group that still meets today. So there have been so many times in this community where we do it together. I would say, please channel this energy around prevention, right? I mean, that is the conversation that is, it's not polarizing, right? We could grab that, and most people are going to, like, it's going to be really hard to find someone that wants to fight you on eat better, exercise, be more connected, right? I'm sure there's someone out there. But if we could harness those things, you'd see this shift in the energy in our community. And I believe that Panhandle Health District has an incredible opportunity to play a role in that facilitating conversations toward future state where, and I loved how he explained it, where our kids are healthy, they're out playing, we're back to who we should be as a community. And I really think there's an intense role for Panhandle Health, and that those partnerships in our community to do something incredible. So thank you for letting me be here and sharing that. Again, it's a real opportunity for us as a community.
Thank you. Kim, you've been quiet.
Thank you for letting me talk. Yes, so Mike, I agree. Thank you so much for your statements there, because I do feel that we have a lot of staff in place for those preventative measures. We have a lot of experts on hand. I'm a registered dietitian. We have several of them. We provide so many preventative services already. And I do agree that, I agree with Director Kettner that we do need to do a better job of providing education to our board about what we are currently doing with those preventative services, and then just continuing to partner with our community partners on our efforts. So.
I didn't mean to pass you up, Jason. You're welcome.
I don't really have much to add to this specific conversation, just because my role is largely within environmental health, but do want to just highlight the partnership aspect of it, and just the unique position that we have as a health district to interface with the counties, with our other partners in various programs, and that's something that we emphasize daily. And I'd love to educate the board more on that in future meetings, just so that give more of an understanding of the the environmental health services that we provide. But yeah, just appreciate everybody being here and opportunity to meet with you.
Well, let's not forget environmental health after all. Hippocrates.
I'll just summarize it. These are conversations that the executive staff are having all of the time. We're looking for ways to do things different, to do things better. We're looking to collaborate with community partners, and so this is the direction that we are heading. So I appreciate everybody being here. I really do. It's been very beneficial.
Dr. Johnson?
I'm so glad that we have initiated this discussion and hopefully take it further down the road so that we really have a positive impact, and we establish that trust so that people can look upon Panhandle Health as a brand of trust, and they're here to support me. And it's not that it's not there, it's like we need to cross that bridge and create that trust and promote that trust. And like we were saying, the programs are there, but and some real supportive work is there, but we need to help get that message out so that those services are being utilized, and the trust goes further so that we can benefit the health of everyone in North Idaho.
Okay, thanks. All right, I'm going to make sort of an executive decision, and that is the meeting is officially over in a couple of minutes, and I want to be respectful to the participants, the principal participants who took their Saturday to come and share in this exercise. So I'm going to, I want to be respectful of the folks who are on Zoom. So here's how I'm going to sort of compromise. if you have come and you're a commissioner or whatever, I'll call the meeting to a close. You can leave if you want. I'm going to stay and entertain the public. I feel an obligation there, but I fully respect it if you want to, retain some of your life. And that goes with your staff. I mean, you guys can leave if you want, or you can stay if you want. I'm not disinviting anyone. Please understand that. It's just that you don't have to do what I'm going to do, is I guess what I'm saying. Is that okay with everyone if we call the meeting to a close, but I'm still going to entertain, or what's the right thing I should do? Leave the meeting open and let them leave, or call it to a... Oh, okay. I like the way you think. There you go. I knew he would have the answer. Okay, well, then I'll take a motion to adjourn. Do we hear a second? We got a second. Any objections to adjourning?
Yeah, I was hoping to dialogue with Mr. Gregg here before he leaves publicly.
Okay. Hearing none, the meeting is adjourned. Now, folks who are participating via Zoom, if I don't know how to make it. Thank you for coming. All right. So how do we? It's going to keep going, but how do we know who's wanting to speak? Oh. Okay. I just don't know how to do that. Oh, okay. Kevin, you want to speak?
Yes.
3 minutes.
Not today. Do you have a business card?
Not with me. But if you can find my contact information on the website. Let me write down the website.
Would you write it down, please?
Yeah. Yep. Yeah, it's
Mr. Camper.
One by one, who wants to speak?
Oh, I can't see them though. Kevin, I'm going to take these folks, and I'll tell you why. Because they've been on for a long time waiting. So if you don't mind, I'm going to... Okay. Brian, do you have anything to say? Are you still on? No, he's off.
I'm still on, Dr. Fletcher, but I don't have anything to add at this time.
Oh, I'm sorry. Go ahead and make your comments.
No, I provided written comments that I think will be. I'll let the public have their time now, so that those comments that I wrote in advance can be considered by the board at a future meeting.
Okay. You may have heard me make a comment earlier, and that is the board will discuss all of the written comments, and in your case, we will submit back to you in writing a response to your questions. Is that acceptable to you?
That would be greatly appreciated. I did hear you mention that earlier, and I thank you for that. And that's why I wanted to just leave the remainder of the time for the public that hasn't had a chance to speak yet. So thank you.
Okay. All right. That's a deal. All right. Who else?
Carl Warren, did you wish to speak?
Yes, go ahead.
No, I'm good. Thank you.
Okay. Tanya Wilson? I don't know. I can't tell if the hands are up.
Yeah, it's different than ours. There's no hands.
I don't know how this works.
Backed out. I think that's it. There's Kristen Dodd.
Kristen Dodd? Kristen Dodd, did you want to? Okay. I think we're done.